All right, let's go ahead and get started. Welcome to the LMU-DCOM Alumni Association's 7th Annual Essentials of Clinical Medicine CME Conference. We're pleased to have everyone both in person and online. If you are watching online, we ask that you are set to mute, and if you have a question, please type it into the Q&A box, and we will have the speaker address it at the end of the session if time permits. If not, we will collect answers from the speaker and distribute the responses to everybody who's in attendance online and in person. All presentations will be available to view on demand online for 1 month following the end of the conference. PDFs of today's presentations are available at LMU-live.com. Attestation forms needed to claim CME credit may be completed by attendees on Sunday at the close of the conference, and these forms will be distributed to in-person attendees and are available online for virtual attendees. Disclosures for all speakers are available for inspection at the office of the LMU-DCOM Director of Alumni Services. Our first speaker today is Mary Beth Babos. Dr. Babos is the chair and a professor of pharmacology at LMU-DCOM. She earned her Bachelor's of Science in Pharmacy from Duquesne University in Pittsburgh, Pennsylvania, and her PharmD from Union University, Albany College of Pharmacy in Albany, New York. She received a Master's of Science degree in Forensic Toxicology and a Master's of Science degree in Pharmaceutical Chemistry from the University of Florida, and she completed a certificate in Cannabis Science at the University of Rhode Island. Dr. Babos is a functional herbalist. Her research interest includes ethnobotany and ethnopharmacology of Appalachian herbs, herb-drugs interactions, and patient-centered pharmacotherapy. Please help me welcome Dr. Babos.
Thank you, Dr. Cope. Thank you, everybody, for being here. I am so honored to be here for the 7th Annual CME event. So I'm here to talk about new drugs, new advances in pharmacotherapy. And as a functional herbalist, one of my favorite topics is cannabis, so I'm grateful for the opportunity to work that in. So I have no disclosures. I will talk about off-label uses of medication, of course, because cannabis is not approved for use by the FDA itself, so there will be some off-label use. The objectives are covered here. And I thought, here's our headlines. So first of all, blah, 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 oral manure, more on flora, oral aura, is bow vow, how sweet you're in, Babs, blabs, mabs, because I call myself either Babs or Babbles. If those of you who have had me know that I can speak more quickly than anybody. So Babs will blab some mabs. A DCOM PharmD who knows jack about stat. We'll look at a kindly new drug that blocks KIND receptors. The new old cure-all cannabis canopy, and finally some news from a generic old mind. Here's the drug, new drug approvals in this century since the year 2000. The gray areas are new molecular entities, or brand new drugs, not Me Too drugs. The dark blue bars are biologic license applications. And you can see that we've had a lot of blahs since this century. So our first blah, blah, blah would probably be define what is a blah. A biological license application is permission to, dispense or distribute a biologic product, something that comes from a living substance that has no clearly defined molecular entity. So if any of you practice oncology, BCG vaccine was once a drug and is now a blah, if you will, because it has no well-defined structure and it is from a biologic source. So our first blahs that we're going to talk about are fecal mycobiotic transplants. So we're going to see if this works. Robert, if you could hit there we go. So please, can you advance to slide 1 for our first polling question? There's a little arrow. No? Oh, there you go. There we are. Oh, yeah. Okay, so sorry, we were having some technological difficulties. Anyway, our first case would be our 72-year-old patient who developed loose stools, experienced 3 episodes daily for 2 days. They've been treated ×2 with fidaxomicin in the last 4 months. Their stool is positive for glutamate dehydrogenase and C. diff toxin by enzyme immunoassay. Medical history is significant for a 20-year history of hypertension and a 5-year history of dilated cardiomyopathy. The white blood cell count is within normal limits, creatinine clearance at the upper edge of normal. What do you want to do first? We want to give her oh, there we go. Now we're working, woo! Okay, so if you could hit the check mark, Robert, please, to show us the correct answer. Oh, or hit stop polling, I'm sorry, there you go. Oh, I didn't realize that things were coming in, I'm sorry. So check mark, SEER 190 VOWST, 4 capsules daily for 3 days. It is, in a patient with heart failure, we really don't want to use monoclonal antibodies, right? So the monoclonal antibody against C. diff toxin would be relatively contraindicated in this patient. So this is just kind of my segue into the new product, which is essentially, oh, Robert, if you could, and I hope I'm remembering your name. There we go. Healthy flora. So we're starting here where our healthy flora is high. When we give patients antibiotics and sometimes even chemotherapeutic agents, we kill off the normal flora. The normal gut flora is one of the things that produces secondary bile acids. Primary bile acids promote germination of C. diff spores, whereas our secondary bile acids are going to decrease germination of these spores. So when we lose our secondary bile acids, it's one of the many causes of increased growth of C. diff. So then we're going to treat the patient with something like fidaxomicin or oral vancomycin. We're going to wipe out the living C. diff organism, but we're going to leave behind the spores. If we keep this repetitive process going on, we get recurrent C. diff disease. So now we have SEER 109, which is essentially, for lack of appropriate terminology, a poop pill. And then we also have Rebiota, which is a fecal enema. When we do that, we get engraftment. We're replacing flora that can now conjugate those primary bile acids, forming secondary bile acids, and eventually restoring a normal flora. So the scoop on poop, SR109, it comes from donor feces. So they treat the screened donor feces, so they're trying to prevent transmission of infectious disease. However, we're not screening for potential allergens. So for SR109 VOWST, they treat it with alcohol to kill everything but the spores, and it ends up containing about 10 to the 7th firmicutes, colony-forming units per capsule. On the other hand, we have Rebiota, which is a fecal enema made again from donor feces. It undergoes filtration using a polyethylene glycol 3350. So patients who have polyethylene glycol allergies, this could be a problem for them. Both of these are indicated to prevent recurrence of C. diff in those 18 years of age or older. So administration, a little bit about it. We want to stop antibiotics before we try to replace the flora, right? I mean, that makes sense. We have some other details here that I'm not going to babble on about. However, one of the things I like to think about from a patient-centric point of care is how much is this going to cost? So for our single treatment with VOWST, it's about $17,500 per treatment. The fecal enema is about $9,500 per enema. And it's a single-time dose. Now, insurance may or may not cover some of this, but I just like to talk about the cost. So more flora or this is just something that I thought was really cool, okay? It's still under investigation. There's a long way to go before we get there, but the people at Baylor University discovered this anti-autoimmune protein produced by the sea anemone. The problem is you have to either give it via continuous infusion or inject it multiple times a day. So who's going to do that? Well, somebody got the idea, let's use recombinant DNA technology, insert the gene that codes for this peptide into Lactobacillus reuteri and see if we can't get a colonization of this organism that's going to release this peptide beyond the lumen of the stomach. So it seems to be working so far. The organism is eventually replaced as the epithelial lining is replaced. However, it seems like a way that we may start delivering more than just the sea anemone peptide in the future. Anyway, not yet FDA approved, but We started talking about our bile salts, so our next topic is bile. Our primary bile acids can promote C. diff spore germination, as I said, while our secondary salts inhibit it. Bile acids, especially the secondary bile acids, do a lot of cool things. So we recently had approved, I think it was in May of 2023, or no, I'm sorry, maybe a little bit earlier, it was September 22, sodium phenylbutyrate with tauroursodiol or tauroursodeoxycholic acid, which I had to practice saying that before I came here. So I drove here and I probably tried to say that for about 2 hours just to be able to spit it out. So Relivrio is the brand name. It's for amyotrophic lateral sclerosis or Lou Gehrig's disease. So I'm just going to say TUDCA for my sanity's sake. It is an anti-apoptotic substance. It is a protein folding chaperone. It activates a sphingosine 1 phosphate 2 receptor. We also found out that it activates certain intranuclear receptors like the farnesoid X receptor, the pregnane X receptor. It activates the Takeda G protein coupled receptor 5. So it does all of these different things. It is going to activate the glucocorticoid receptor, which is thought to help reduce some of the apoptosis that occurs when there's excess excitotoxicity. Our sodium phenylbutyrate is a glutamate scavenger. So you've probably heard of glutamate excitotoxicity. So that's really what we're trying to do here is reduce the amount of reactive oxygen species formed and help prevent apoptosis of neuronal cells. If you care, glycerol phenylbutyrate is also used in urea cycle disorders. So for ALS, we have this secondary bile acid. The tauroursodeoxycholic acid is really produced more by the rodents than humans. We have a tendency as humans to glycinate, not taurinate, but that's another story for another day. Cost of this is about $158,000 a year, which I think is a little on the high side. I think that's more than I paid for my house, right? Recently, if you care, and I was speaking with Dr. Jones about this earlier, she's going to be talking about non-alcoholic fatty liver disease. They recently the FDA recently denied obeticholic acid, which is another bile acid analog for non-alcoholic fatty liver disease. If you were watching that, it got denied last month. Anyway, back to our story is bile. There's a lot of different pathways. I chose this graphic not to talk to you about it at length. I gave you in the notes view, you can see the caption. I've also included it in your references, but I kind of liked it because, we have this balance between apoptosis and anti-apoptosis. So in things like ALS, having excess apoptotic activity in neurons means our neurons degenerate, right? When we get too many of our MABs, we're going to want to perhaps induce apoptosis of some of our immune cell lines for autoimmune disease. So it's always a fine balance. But the main thing I wanted to point out here on the left side of this relatively busy graphic is that really what we're doing with these secondary bile acids like TUDCA is reducing oxidative stress. When we have the excess calcium release from the endoplasmic reticulum, we can induce mitochondrial apoptosis also. So there's a lot of different pathways. On the right hand of this busy slide towards the bottom, we're seeing that we're turning off apoptotic pathways in our neuronal cells. So the bottom line in amyotrophic lateral sclerosis is we're losing neurons. This combination of TUDCA with the sodium phenylbutyrate can perhaps delay the progression of the disease. Here's the announcement from the FDA. The dose is 1 gram packet, 3 times per day, for 3 weeks and then twice daily. It really has a lot of sodium, and there are some cautions for those with existing GI diseases. While we talk ALS, torfersen was also recently approved. This was in April of 23. It is an antisense oligonucleotide to prevent formation of some of those proteins that are formed in the few ALS patients who have SOD1 mutation. The couple problems. Number one, it's intrathecally dosed, okay? To my mind also is the cost. It's gonna be about $392,000 per year. We're seeing myelitis radiculitis, complications with glaucoma, aseptic meningitis, at least in the trials, so we'll see how that goes. We also have edaravone, which is thought to be a free radical scavenger. at a cost of about $171,000 per year. But the limitations we're seeing with this new medication is severe hypersensitivity reactions. So we'll see how that goes. So these are kind of orphan drugs, so I'm trying to get information out there on lots of different topics to meet all your needs. See, I really can talk fast, can't I? So how sweet you're in. Several new drugs to treat and manage diabetes. I think I failed to mention that, think about our bowel salts, right? We eat fatty foods, we eat proteins, we get bowel acid secretion into the gut. There is some evidence that activation of those farnesoid X receptors and that Takeda 5G protein coupled receptor may increase glucagon-like peptide 1. There's some satiety involved when we release bowel acids into our GI tract. So let's talk about some new drugs for diabetes. It's going to be my segue into GLP-1. So we're all familiar with the life and limb saving GLP-1 agonists, the incretin mimetics like the liraglutide, which is Saxenda, the oral semaglutide, Ozempic for diabetes, Wegovy for weight loss, right? So they're working on the right-hand side of this graphic to delay gastric emptying, to increase satiety. There's some cardioprotection. We're also decreasing glucagon release. The GIP peptide, which is released by the K cells of the intestinal tract, is hepatoprotective, increases lipolysis, so there's some benefit for weight loss there also. And it's also going to decrease bone resorption. So one of the things when you're thinking about managing your diabetic population, many of the medications are going to promote bone loss. So tirzepatide may or may not help prevent bone loss from diabetes management. If we look at the SURPASS trial data that was published in 2022, it's comparing tirzepatide to all GLP-1 agonists, and we're really not seeing any statistically significant differences. Here's a comparison of our GLP-1 agonists. So far, tirzepatide price-wise, and this is from GoodRx pricing, it's about in the middle of the pack, right? We're ranging from about $600 a month up to about $1,300 a month for these products. If you're interested, Novo Nordisk has the OASIS 1 trial currently underway, which is a 50 milligram dose of semaglutide oral for weight loss with some promising results. So the weight loss from these GLP-1 agonists, has kind of changed some of our thoughts about the metabolic syndrome. One of the problems is patients don't want to go on the needle. So here's perhaps an oral opportunity to modify that. While we're on dual agonists, up and coming is cotadutide, which is not yet FDA approved. It is a glucagon GLP-1 dual agonist. So the advantage, you're like, glucagon, why would you want to add glucagon to a diabetic patient? Well, the GLP-1 kind of overrides the hyperglycemic effect of the glucagon, while the glucagon itself is providing hepatoprotection. So this drug is seeking an indication for patients with type 2 diabetes who also have non-alcoholic fatty liver disease. We'll see how it goes. This is a trial that's involved 700 plus patients. We're finding, equal decreases in A1C to an anti-diabetic dose of liraglutide. We're seeing increased weight loss compared to an anti-diabetic dose of liraglutide. So, it would be interesting to me if we used a weight loss dose of liraglutide, but they were using 1.8 milligrams, which is the diabetes dose. So we'll see what comes out of this drug. Also, and this is cool, I just started teaching veterinary pharmacology this year, so I was learning about bexagliflozin, and it was under Bexacat. So in diabetic cats, we use an SGLT2 inhibitor, Bexacat. It recently got approval by the FDA for use in humans under the brand name Brenzavi. If you look at the data on the far right of the screen, we're seeing statistically significant differences in A1C and albuminuria compared to placebo, but we're really not seeing cardiac benefits. Kind of the same with many of our other SGLT2 inhibitors. If you care, I put together this slide of some significant trials of SGLT2 inhibitors, and I put in bold those that produce statistically significant differences in cardiovascular outcome. So we did find it in the Canvas trial with canagliflozin, with the Credence trial with canagliflozin, and then also with dapagliflozin. Not uniform across the boards. It may be dosing, it may be trial design related. The bottom, the composite of renal hazard ratio, some of them do produce, and I'm wrong about something every day, you know, I really am. This is one thing that I was really wrong about when these drugs first came out, because I thought, yeah, it doesn't make any sense to increase spilling glucose into the nephron, because that's what's causing the damage. But now we're finding that they're actually, renal protective in many cases. If we care, here's our comparison with our costs. The price for the bexigliflozin wasn't available when I last checked. So segueing into some practice guideline updates, now our SGLT2 inhibitors are indicated to delay progression of diabetic kidney disease and proteinuria, first line in heart failure now. So that's a pretty significant error on my part back in the day. That was something I didn't predict. Also, I don't know if you're aware that ADA and ACE guidelines for diabetic management, finerenone, Kerendia. Finerenone is a non-steroidal mineralocorticoid receptor antagonist. So our choices in the past were spironolactone or eplerenone. Now we also have finerenone. And the advantage of it being non-steroidal is that unlike spironolactone, it's not going to mess with the hypothalamic pituitary gonadal axis. It is also equally distributed between cardiac and renal mineralocorticoid receptors. So I think we'll probably see a significant decrease in cardiac remodeling driven by aldosterone in our diabetic patients. Okay, so coming soon, I don't know if you are aware, but insulin icodec by Novo Nordisk is a once-weekly insulin. So we are seeing in some of these trials, like the Onwards 5, that equal efficacy of this once-weekly insulin injection compared to our long-acting basal insulins like glargine. So this is something up and coming. I'm thinking probably late this year, early next year, it may be up for approval. Oops, there we go. Oh, thank you. So now we have a 12-year-old who tests positive for glutamic acid decarboxylase antibodies and insulin antibodies after oral glucose tolerance test. Revealed dysglycemia. The family history is positive for type 1 diabetes. After we gave an infusion of an anti-CD3 antibody, the patient developed fever, vomiting, headache, dyspnea, and hypotension. Which would be the best pre-treatment for this patient? So I don't know how long you, oh, there we go. We got some responses coming in. Yay. So I was just trying to make this interactive, and rather than me just babbling on. And go ahead, sir, if you would like to close our polling, and we'll. So our polls say, boink, most people said dexamethasone plus famotidine. The actual correct answer is Tylenol plus an antihistamine plus ondansetron. So one of the things I really wanted to talk about is, what is this anti-CD3 drug? What? For type 1 diabetes? This will also be our segue into BABs, blabbing MABs. So teplizumab, TZIELD, is an anti-CD3 antibody that's indicated to postpone the onset of stage 3 type 1 diabetes in patients who are currently at stage 2 who are at least 8 years of age. It's about $194,000 for the regimen, and it delays the onset, as you can see from the graphics, of diabetes by about 2 years on average. If you recall from immunology, the CD3 protein is a part of both the CD4 and CD8 T cell receptors on our CD4 positive and CD8 T cells. Teplizumab binds to that CD3 protein, which can actually turn on the T cell. That's why we're seeing this cytokine reaction syndrome that we saw. But it has a substitution of leucine for alanine at the FC portion, so it does not activate the effector cells. So, segue, as I said, BABs, blabbing MABs. Woo! Monoclonal antibodies. I feel sorry. You know, when I went to pharmacy school back in the day, there were only 5 drugs. It was really easy. It's really easy to be a pharmacist. Now you guys got all these MABs to learn, and they all sound the same, right? Here's the expansion of MABs since the first one came out, Miromonab, which was an anti-thymocyte immunoglobulin. It would be a blah today. So anyway, MAB targets. We're looking here at cancer versus other targets. It's just ever expanding. So there is nomenclature and there are nomenclature changes. I love that when they realized that this market was going to expand so rapidly, that they came up with these influxes that tell you what the target is going to be. That's what I tell like my, first and second year med students. If you know at least the influx, at least you have an idea what we're targeting. So in the case, we've already seen teplizumab, so L or Li is usually the immune system. That's where many of our antibodies are. Prior to 2017, we had a substem that indicated the source, but after 2017, that is no longer the case. Prior to 2022, it was easy to tell it was a MAB because it ended in MAB, but now they've changed that too, so that we will be seeing, I don't think any of them hit the market yet, TUGs for modified immunoglobulins, MENTs for fragments, MIG for bi or multi-specific immunoglobulins. There's also a 4-letter random suffix after the drug name, and I looked for this for, I don't know, probably 4 to 6 months. Like, what are these random letters? And that's what they are, is random. There's so many biosimilars coming out now that 4-letter identifier is a way to differentiate the original product from the biosimilars that are hitting the market. So our infusion reaction, cytokine release syndromes, we get infusion reactions anytime we infuse a protein, okay? When you infuse a protein into a patient's body, you're probably going to see some immune activation, fever, chills, itching, dyspnea, pain, nausea, vomiting, diarrhea, rash. But we can have a very severe syndrome, the cytokine release syndrome. It is an acute systemic inflammatory syndrome with organ dysfunction associated with immunotherapies. So our chimeric antigen receptor T cells are MABs, but also COVID, as all of you, I'm sure, are all too aware. We also have this immune effector cell-associated neurotoxicity syndrome where the cytokine response starts to cause an encephalopathy. So why does this happen? So in the right-hand corner here, I'm showing you a T cell with its, this is an MHC, or CD8 T cell interacting with an MHC1 on a tumor cell. The tumor is presenting antigen. Expressed on that T cell is that PD1, the programmed death receptor 1. Our tumor cells express programmed death receptor ligand that prevents that T cell from being activated. It's like, hey, no, I'm fine, really. It's cool. Don't attack me. I'm good. So we came up with drugs like nivolumab that prevents that PD-L1 interaction. So now our T cell's activated, starting to kill our tumor cell. The T cell is going to release cytokines, TNF-alpha, interferon gamma, interleukin-1, that is then going to kill the tumor cell. The tumor cell will release damage-associated molecular pattern proteins. All in all, we're going to get activation of our innate immune system, macrophages, dendritic cells, et cetera, that in turn are going to release things like interleukin-6 and interleukin-1. These are what cause fever and chills and the symptoms that we're seeing. We also get activation of the endothelial cells, leading to an inflammatory type of programmed cell death known as pyroptosis. So apoptosis is an anti-inflammatory controlled cell death. Pyroptosis is what we're seeing and what we have seen in the cytokine release system associated with SARS-CoV-2, right? COVID-19. To move on to our biphasic type of antibodies, when things like blinatumomab, that's a hard one to say, binds to the CD3 on the T cell and the CD19 on the B cell, they both get activated. We have our chimeric antigen receptor T cells. Everybody aware what those are? We're taking T cells from a patient and changing the T cell receptor to recognize antigens specific to their tumor type. So when we get that modified T cell interacting with the B cell, we get release of all these cytokines, damage-associated molecular proteins, leading to a cytokine release syndrome. or other older drugs that bound to the CD20, like rituximab and obinutuzumab. When the immunoglobulin itself binds to the B cell receptor, it turns on the B cell, but it also, which causes interleukin-1 release, but it also activates the natural killer cells. We get cytokine release syndrome. Sorry for that, like everything I know about immunology in 2 minutes or less. But this is just something that you can predict is going to happen when you're infusing antibodies that are going to interact with immune cells. So here's blabbing the new mAbs, right? We have vilobelimab, which is an anti-complement, activated complement 5, anti-C5 antibody on emergency use authorization for patients with severe COVID-19. I don't have a price because it wasn't available. It just hit the market in May. Epocortamab and mosunetuzumab. Notice we have the T in that influx. These are anti-cancer monoclonal antibodies. They both target both the CD3 protein on the T cells and the CD20 on the B cells to essentially activate both of them. The former being for B cell lymphoma, the latter for being for follicular lymphoma. Pretty pricey though, $180K for an 8-cycle course of the latter. Lecanemab, can anybody say that for me? Lecanemab, thank you, is an anti-amyloid beta antibody. I'm sure you guys all saw this in the news. A lot of criticism for the FDA for how rapidly that this drug was approved. It is an anti-amyloid beta antibody. We're seeing microhemorrhaging, of course, amyloid related imaging abnormalities, and a lot of edema. Its price is about $26,000 per year. And the efficacy was really not that great, in my opinion. Has anybody seen this used, like, clinically so far? No? Okay. Retifanlimab is an anti-PD-1 antibody, much like nivolumab. This is for a Merkel cell tumor. I think tisotumab is one of the coolest drugs ever. So cervical cancer expresses a lot of tissue factor. So we made an antibody against tissue factor that delivers an M-phase specific cytotoxic chemotherapeutic agent to kill those cells. But the problem is that tissue factor is expressed by lots of tissues, including ocular tissue in the epithelial cells. So we're seeing a lot of ocular toxicity with this drug. Interestingly, parasolimab and rosnilimab are activators of PD-1 that are used to kill T cells in autoimmune disease, to induce apoptosis. They're in phase 2 trials. And if you were using the spike protein monoclonal antibodies, their emergency use authorization has been withdrawn because they're not effective against Omicron. Moving on to knowing Jack about STAT. Not that these are brand new, spanky new drugs. However, it's going to be probably, at least a $500 million market by the year 2030. And there are some new boxed warnings involved with these drugs. Jack comes from Janus, Janus kinase. Janus was the Roman god of gates. So these four different proteins, JAK1 through 3 and TYK2, dimerize on cells, and when activated, they autophosphorylate and cause phosphorylation, the signal, the STATs, the signal transducer of activators of transcription, to increase proliferation of often immune cells. A recent article was talking about the JAK inhibitors in dermatology, so you can see the indications here are largely dermatology, but also some immunology. I don't really want to talk specifically about the indications, but rather to illustrate that mechanism that I talked about, where when we activate with the different cytokines and growth factors, we get dimerization of those STATs that enter the cell and increase production of proliferative signals. So our JAK inhibitors are going to prevent that from happening. New warnings, though. Tofacitinib, baricitinib, upadacitinib, serious cardiac events, blood clots, cancer, and death. We have some agents like ruxolitinib and fedratinib that are used for things like myelofibrosis and some polycythemic graft versus host diseases. Since those aren't inflammatory processes, those two drugs are excluded from the FDA warning. However, in the European Union, they really put restrictions on the use of these medications first line, especially in older patients, those who smoke, those who already have underlying cardiovascular risk. So if you're wanting, my thought, if I were in general practice, I had a patient on one of these drugs, I really want to watch closely for increased risk of cardiovascular disease. Finally, a kindly new drug that blocks KNDY, I spelled wrong on here, sorry, neurons, something that I could use at my age for treatment of menopausal hot flashes. So, sir, if you could, we have a 58-year-old vegan with, I can't even see my slides here, BMI of 22, she's got fatigue and dysphoria. She endorses that she's getting hot flashes frequently with sweating. Densitometry reveals a Z-score of minus 0.5, past medical history, last menstrual period 6 months ago, intact uterus, has had 2 unprovoked VTEs. She's on fluvoxamine for OCD, obsessive compulsive disorder. She's heard that Veoza, 45 milligrams daily, might help. Which of her concomitant conditions is a contraindication to use of this medication? All right, sir, if you want to progress for me, you are too kind. The correct answer is fluvoxamine. Veoza is metabolized primarily by CYP, which is going to be inhibited by fluvoxamine. So this drug, I really found kiss peptide. I wonder who named that protein, right? Kiss peptide. If you look at the lower right, we're looking at, in purple, a gonadotropin-releasing hormone neuron. And we see that it's activated by that protein called kiss peptide. The neuron towards the right is a KNDY, kindy neuron. We see that KNDY neurons are inhibited by both dynorphins and estrogen. So in menopause, we're losing inhibition of this neuron, and activated by the neurokinin-3 peptide. So this drug, fezolinetant, is a neurokinin-3 receptor antagonist. It's going to cost about $550 a month, so kind of pricey. More alarming to me is, hepatic damage risk. So we have, an aging population exhibiting menopausal symptoms, and I know that I used to be thin and I'm not now. Risk of type 2 diabetes, non-alcoholic fatty liver disease is going to increase with time, so I'm kind of alarmed about adding a potential hepatotoxin. Contraindicated known cirrhosis and with concomitant powerful CYP1A2 inhibitors like fluvoxamine. Cannabis, canopy. Sorry, this is one of my favorite topics. Like I said, I'm a functional herbalist. I love plants. I'm passionate about plants. I tell my students all the time that I'm really kind of a prostitute because, I'm a pharmacist. I sell drugs. I teach about drugs. When really what I'm passionate about is plants and herbs. So cannabis, the receptors are endocannabinoid system widely distributed in the body. Almost every tissue. Our CB1 receptors being more globally distributed, but our CB2 receptors primarily in our immune system. We have endogenous ligands that are autocoids. They're generated on demand, and really in the CB1 receptor realm, it's so cool that they are generated by the postsynaptic neuron to turn off excess signaling by that presynaptic neuron. So they reduce glutamate excitotoxicity, and you guys are probably saying, well, give her some of that, would you? Chill her out. I'm actually so passionate about plants and cannabis. I said to one of my colleagues, I'm worried that people are going to think, I'm a stoner because I talk about cannabis all the time. And she's like, maybe they'll think that you're, a meth person because I'm just not chill enough to be a stoner. So I just want to make that disclaimer. I am not. Anyway, so it's complicated, right? On the left, we're looking at, these are some of our endogenous cannabinoids. On the left, we're looking at our N-acyl neurotransmitters. I apologize in the middle that it says N-acyl ethanolamines, but it's actually N-arachidonyl ethanolamines. That's a typo on my part. And then on the right, we're seeing our actual N-acyl ethanolamines. We're looking at PPAR alpha, PPAR gamma. These are master regulators of metabolism, right? So there's a, wow, it's just so complicated. At the bottom, we're looking at some of the different receptors that are activated also. CAV is a voltage-gated calcium channels. We all know about using some of these agents for epilepsy. So, I mean, essentially, gabapentin, not a great anti-epileptic drug, but gabapentin and pregabalin are going to prevent activation of these voltage-gated calcium channels. Many of our anti-epileptic drugs work on these voltage-gated calcium channels. So perhaps, explaining some of that anti-epileptic effect. TRPV ion channels stands for transient receptor potential vanilloid receptors. It gives you the hot in hot peppers, right? Capsaicin is an activator of these TRPV1s. Thing about ion channels, though, if you activate them too much, they desensitize. So these TRPV1 channels are located to modulate neurotransmission. They're also responsible in part for nociception. When we stimulate them with some of our endocannabinoids, we initially activate them, but followed by desensitization. Our GPR 110, 55, 119, the formerly orphan receptors that we now know are really involved in control of glucose. So it's an amazingly complicated system. If we look at the anti-neoplastic effects, on the left we're looking at the CB1 receptor, at the right the CB2 receptor. There are two canonical, well-known cannabinoid receptors, as I said, 1 and 2. So when we activate the CB1 receptor, we are going to turn off the ERK pathway. Therefore, we're going to inhibit cell cycle activation and proliferation. Our MAP kinase P38 BCL2 pathway, usually anti-apoptotic, but there is some context that's there. If we move on to our CB2 receptors, we're probably going to turn on our caspases, which would have an apoptotic effect. But we also see some effects on our VEGF, matrix metalloproteinases that promote angiogenesis and invasion. We also see some activity at the Wnt beta-catenin signaling pathway. And if you're aware of the conversion of hepatic stellate cells to fibroblast cells in cirrhosis, that's the pathway that's partially responsible. So there's a potential here also for fatty liver disease. Anyway, our topic is really the cannabinoids. Oh, sorry, I forgot to put this slide in here. So CB2 receptor activation, just a summary of the effects. We're seeing that despite that their location is predominantly on the immune cells, we're seeing pretty global effects. I wanted to point out that the SIRT1, PCG1 alpha, AMP kinase pathway really involved in metabolism. Metformin activates the AMP kinase pathway. The PG1 alpha pathway stands for peroxisome proliferator activated receptor gamma cofactor 1 alpha. So we're really looking at a master metabolic regulator here. Here we're seeing our JAK-STAT inhibition, perhaps promoting some anti-inflammatory effects. Our NERV2 is one of our primary antioxidant, anti-inflammatory pathways. Here's our phytocannabinoids. Here's the stuff that people are talking about. So they all stem, our primary cannabinolic derivatives stem from cannabidiolic acid. There's 3 primaries, the cannabachromic acid, the cannabidiolic acid, and the tetrahydrocannabinolic acid. You hear about people talk about decarboxylation, right? I don't know. I mean, maybe you don't, but I do in the worlds that I visit sometimes. But really, it's just heating. If you know anything about pharmacokinetics, those carboxylic acids on our precursors prevent ability of that precursor acid molecule to diffuse across membranes. So when we heat it, we get rid of that carbolic acid. Now we see CNS absorption orally and CNS penetration. You might hear the term entourage effect. There are hundreds of compounds in every plant, including cannabis. So many of the constituents will work together to give us synergy, additive effects, and antagonism. It's actually kind of cool, the complex interactions. This was a great a mapping review done in, I think, 2021 One of the most rapid responses I ever got to asking to reuse somebody's graphic, because the original author's from Middlesboro, Kentucky. And when she saw an email from LMU, she's like, yeah, go ahead, I'm from Middlesboro. She's at University of Florida now. But the size of the circle in this mapping of systematic reviews, the size of the circle indicates the number of studies they looked at. Where it has a little asterisk inside the circle, that's a meta-analysis that was done. The color of the circle corresponds to the disease state. And then, of course, on our y-axis, we're looking at the bottom at low, really bad quality of evidence, towards the top, good quality of evidence. And then across the x-axis, whether the condition was improved, whether it was iffy, or if the condition was worsened. So in that upper left-hand quadrant of this cluster analysis, we're seeing the great benefit that at least I would expect in chronic non-cancer pain, some great benefit in epilepsy. The evidence for cancer, though, is equivocal at best. A great article, great review article, if you're interested in the topic. CB1 receptor, though, I mean, the good, the bad, the ugly, the CB1, THC activation of the CB1 receptor is the bad part of the plant. So on the left, we're looking at acute activation. When we acutely activate the CB1 receptor with THC, we're going to decrease release of GABA, because as we said, it's an inhibitory, retrograde inhibitory signal normally. So we may get either increase or decrease anxiety, we get some reward, we get euphoria, it's what causes the red eye, the dry mouth, the tachycardia, the hunger, short-term memory loss, sleep. And I don't know if you remember the bout of the face-eating zombies. They were doing bath salts, I think it was, really potent THC1 receptor, CB1 THC analogs that actually cause psychosis. So where you have patients who have an underlying predisposition to schizophrenia, their use of a potent THC-containing chemobar can actually unmask schizophrenia. When we have chronic use of high-potency THC, we're going to see downregulation of our CB1 receptors. So tolerance, people will need higher and higher doses of THC. We're also, though, one of the byproducts of degradation of our endogenous cannabinoids. So when we have downregulation of our CB1 receptors, our body's responding, trying to say, hey, I need some more signal. We increase AEA and to N-arachidinoglycerol production, which in turn is going to increase formation of arachidonic acid. You guys know arachidonic acid increases leukotrienes and prostaglandins to actually increase inflammation. So chronic use of cannabis is probably, high THC containing cannabis is probably a pro-inflammatory state. We can also have withdrawal. When the patient suddenly stops the THC, we do have a known cannabis withdrawal syndrome. Oops, wrong button. Scromiting. Scromiting is one of my favorite things. Now, we found now that constant use or chronic use of high-potency THC chemovars causes this cannabis hyperemesis syndrome. Typically in younger males with a chronic history of high-potency cannabis abuse, and they show up vomiting and screaming in pain, scromiting, right? They say that they take hot showers because it's the only thing that relieves them. Well, I talked briefly about those TRPV1 receptors. What happens with chronic use of high-potency chemovars is those TRPV1 receptors get desensitized in the solitary tract nucleus, in the dorsal root ganglia containing the vagal nerve. When those TRPV1 receptors get desensitized, those centers get activated. That's what makes us vomit, right? So that's causing the scromiting. Tolerance to THC is what's causing the pain. Current treatment for temporary management of this is application of capsaicin, hot pepper cream to the belly button, to the periumbilical area. The only cure is quit smoking pot, right? That's the cure. Quit doing it. There's drug interactions also with THC and CBD. So we get our pharmacodynamic expected effects at the left. At the bottom, always our low therapeutic index drugs are a concern. At the top, protein binding. These are really lipid-soluble substances, so they need to ride around on our plasma proteins. And at the right are those that concern me the most, particularly our possible induction of some of our CYPs, and then also the CES1 inhibition. Most of our ACE inhibitors are prodrugs that require action of carboxyesterase for activation. So patients who are using cannabidiol, cannabis, if their blood pressure was formerly controlled with an ACE inhibitor, you may see loss of control from loss of activation of these ACE inhibitors. The two exceptions are enalapril and trendolapril. So if you have a patient who's going to continue using cannabis products, probably switch their ACE inhibitor. You could use an ARB also instead. Finally, babbles will quit babbling, new from a generic old mind. Here are, I'm not going to read this slide to you, but I just wanted to say, hey, you know, there's some generic drugs coming soon, including dapagliflozin, saxagliptin combination, and liraglutide. Wow. Can you believe I did all that? I know those of you who've had me in pharmacology class are like, oh, wow, that was kind of slow for you, Babbles, right? But I do speak quickly. I'm happy to take questions from the audience or polling. Thank you so much for coming here. I really am so happy to see so many of you that I haven't seen for a while who are now white smart physicians, PAs. I see some of you that I've known.
From the audience.
Rob Stapleton, Family Medicine, Jacksonville, Florida. It probably nationwide, but at least in Jacksonville, you can't get semaglutide at all unless it's the 1.72 or 2.4 milligram dose. What are your thoughts on the compounded semaglutide salts or the semaglutide B12? I mean, I can parrot what the FDA says, but patients just don't have any other options, at least where I am.
I'm right where you are with that. They are, my official statement is they are not FDA approved and have not been tested. They are not the exact identical molecular entities because they are salts. Patient-centered care says you do what is the best for the patient and causes the least harm. We don't have a lot of evidence for benefit or harm of these. I've kind of been watching that in the news. I've not seen any evidence of harm emerging, but whether that benefit is still there or not. So that was my politician's way of saying, I'm not going to answer that question because I don't know. I agree with you though, like what are you going to do? Thank you, that was a great question.
Any other questions? I think as I was listening to this lecture, for those of us who's had the privilege of being taught by Dr. Babos, number one, I don't miss her test questions. But number two, for those of us who had the privilege of going to LMU, you know, we really did have a great privilege of being taught by brilliant people like Dr. Babos and, you know, people that set us up for success in our careers. And so I think I'm more appreciative every day of that aspect of my education. So thank you, Dr. Babos. We appreciate it.
Thank you
all. All right. Why don't we take like a 3-minute break real quick, and then we may start a little early for the next one, just to try and keep us as on time as we can. All right, we're going to go ahead and get started on the next lecture. And just for everybody's information, there are snacks and drinks located down the hall here in case you get hungry. Our next presenter is Dr. Angela Cope. She currently works as a community physician at Liberty Mountain Pediatrics in Birmingham, Alabama. Prior to working at Liberty Mountain, Dr. Cope spent almost 5 years at Christ Health Center, which is an FQHC that serves an urban and underserved population. While she was there, she served as a clinical associate professor for the St. Vincent's Family Medicine Residency Program and assisted with their pediatric curriculum. She is currently clinical adjunct faculty for the Alabama College of Osteopathic Medicine and for the PA programs at the University of Alabama at Birmingham and Samford University. So it's my pleasure to welcome my better half, Dr. Angela Cope.
Okay, well, good afternoon, everybody. I'm glad to be back with my DCOM family, and I have one residency colleague back there, so I'm glad to be here. I'm going to be talking about pediatric dermatology today. So, all right, just need to figure out how to. Oh, there we go. Okay, before we get started, right? I'm not that cool. I don't have any disclosures for you guys. So. Okay, so what we're going to talk about, really the goals of my lecture today, is for everyone in here to be able to recognize or refresh yourselves on pediatric dermatological conditions, which those conditions today we're going to focus on rashes, right? Because everybody loves rashes. So we are going to kind of get confident with those rashes. Also, I want to kind of spend time with each rash and point out some key features, because rashes, right, this is why we don't like them, is because they can be very tricky, and it can be like 5 billion different things. So I'm going to try to help give you some really good key features to help make sure that you are able to differentiate those things and get you more confident. And for this lecture, you'll see for each rash that I have, there is a trick behind it. There can be a rash that looks very similar to it. And so I'm going to try to spend time and pick those differences out for you. Also, for each one, we're going to talk about treatment. Okay, so starting like history, right? History is crucial with diagnosing anything. But I'm not going to spend a lot of time on this slide. What I do want to point out specifically for pediatric patients, age of the patient, right? That's kind of an extra key feature in your history that you want to pay attention to. So for example, eczema. Eczema has what I call eczema hotspots, but it can be different in different locations and look a little different depending on the age of the patient. So an infant is going to have eczema spots mostly in different locations, and we'll talk about those in just a second. Also, environmental factors. You know, a lot of times we ask, like, we see this rash and we're trying to, find like a needle in a haystack, like, I don't know what this rash is. So you're just like, well, did you change anything? Did you change, soaps, lotions, any moisturizers? For babies, very, very commonly, it is not uncommon at all to see a baby who comes with like this diffuse rash, and you're like, that looks like a contact dermatitis rash. And I don't know if you guys have the same patients that I have, but I have to have to be very specific with them. So if I say, did you change anything? They automatically say, no. I'm like, are you sure? No. And we'll go round and round, right? I have to be specific. For babies, specifically, moms, grandmas, they love to wash their babies in baby wipes. And so a lot of times they don't think that can be irritating, but babies have very sensitive skin. And so very commonly I have to say, have you been using baby wipes? And they'll say, oh, yeah. We remove the baby wipes and usually the rash goes away. So just keep that in mind. Okay, physical exam. Not going to spend a lot of time on this slide because we're in a time crunch. Just definitions here in case you need them, just to make sure that your documentation and communication is on point. Okay, another physical exam things. kind of want to point out important things that sometimes we forget about. One is secondary morphology, right? That's when you have a primary rash or a primary skin lesion, and then over time it can change. Like you have secondary features, like for example, lichenification. That happens, like with eczema, when a kid has just been scratching and rubbing chronically and their skin changes from a primary eczema rash. And that's where it gets like real dry, they're wrinkly in that area. So, okay, diagnostic tools. So don't forget about these. These can help you rule in, right, or rule out a diagnosis. Clinically, what I use the most is the culture because it is very time efficient. I don't really have time sometimes to go and, get a microscopic slide and look under a microscope just because in pediatrics, we're high volume. We move people in and out very quickly. I need something that is a little bit more time efficient. So for me, I go see the patient if I, for example, think that they have tinea capitis. The treatment for that is a little bit more, right, from a medication side effect profile. We have to use like grisofulvin or oral antifungal to treat that versus a topical ointment. So I really do like to confirm those. I may not delay treatment. I may go ahead and start them on grisofulvin, but I always have a culture for confirmation just in case it's not working out, like the rash is not improving, and maybe it's psoriasis instead. So I do culture those really easily. Just a quick tip if you don't know how to culture them. I usually will get like either a tongue depressor or even a microscopic slide and just kind of get the skin cells loose in that area. And then I take the culture swab and I kind of get it moist, tap water, sink water, moisten a Q-tip, and then I go and rub that area really good, send it off for culture, boom, done. So that's kind of how I do it. Woodlight exams, does anybody use Woodlight's lamp like very often? Yeah, because it's not that time efficient either. You have to go get the nurse and she has to figure out where they put the Woodlight lamp, right? It just takes a long time. So the only time I would use it is like if I didn't know like if a tinea versicolor rash was confusing me with maybe like a pityriasis kind of rash. Turn the lights out, light it up. If it glows in the dark like a yellow golden color, right, it's tinea versicolor, boom, you're done, right? One of my old attendings, he used to use Woodlight's lamp for tinea capitis. I don't do that, and the reason is because Woodlight's lamp, if you're looking at a tinea capitis under Woodlight's lamp, it's only going to confirm about 5% of those. It's only going to pick up the species Mycosporum. It's not going to pick up your other species that can commonly cause tinea capitis. So for those reasons, I don't use it because it's not very helpful. Okay, differential diagnosis. I have a whole slide on it because it is super important in medicine, but specifically for rashes, it really does save me a lot, and it helps me feel confident. If I usually have like a running list of at least 3 different diagnoses, because rashes are super tricky, right? Then I can kind of go down the line. This rash looks most like number 1, and I'm gonna treat it this first, right? Or if treatment number 1 didn't work out, then I kind of go down the list of my differential and see, okay, let's try this treatment. And I have examples of those where I've actually done that. Okay, so this is also going to be very interactive. This is a rash, right? It is one of my patients. Does anybody have a guess what this rash is? Don't be afraid either. It's okay if you're wrong. How old? They're 16, 16-year-old female. Good question. A little bit, not really. Great question. So the patient does not have a hair patch today because she really just has this diffuse rash on her chest, back. Asked about a hair patch. She didn't really recognize one. Good question. Anybody else got a question? Does anybody have an answer? It's okay if you're wrong. Nobody else, okay. So this patient actually presented to me. It was a 16-year-old female, actually started, I probably was like in my 2nd or 3rd month, being a brand new attending, I had an ACOM third-year medical student. I had her go see the patient. She came back to present the patient to me, and was very confident. She was actually very excited because thankfully the night before she said that I just studied pediatric dermatology and I know what this rash is. And I was like, oh gosh. And she's like, it's pityriasis rosea. Yeah, I look at her and I'm like, yeah, you're describing pityriasis rosea. Go see the patient. It probably is pityriasis rosea. But I went to a really good medical school called LMU-DCOM, and I was taught from the very beginning to do a head-to-toe exam, right? So the first thing when I go see a rash on a patient is I go head to toe. I always kind of go down their arms and I say, give me your hands. Put their hands in mine with gloves, okay? Because I don't know what the rash is. And so I hold her hands, and I found one little spot on her thumb. I thought, well, brought the student out and I said, well, you know, pityriasis rosea really doesn't have a rash on the hands. So that's kind of like, doesn't really fit all the way with pityriasis rosea. But I was like, I agree, the rash does look like pityriasis rosea. So I said, well, you know, we're learning, so for funsies, let's just get an RPR and just make sure this isn't syphilis. By the afternoon, we had a 1 out of 64 RPR positive. So we sent her to the health department. She got penicillin G. It was confirmed syphilis. And she came back to me. She ended up being like one of my favorite patients. But she came back to me and she said, Dr. Cope, I really think that I'm allergic to that antibiotic they gave me. And I said, why? She said, because I got fever, I got chills. She obviously had, you know, one of those reactions that we learn about in medical school, and it was syphilis. So I learned a lot. The medical student learned a lot. And so my point is definitely do a good head-to-toe exam with rashes and keep a good differential in your tool belt. So, all right, here's a lookalike, right? So if we go back, I can't go back, but thank you. So, right, this rash looks identical to this rash, right? So that's pityriasis rosea. Most commonly, whoever asked that question about the Herald patch, yeah, patients, if you can time it right. A lot of patients don't think much when this Herald patch comes up, or they may not even see it. They may just be scratching and going on about their day. But typically, they will have a Herald patch. About a couple weeks later, they will get this kind of diffuse rash on the back. It can also mimic like a viral exanthem. It can mimic hives sometimes. So hence, rashes are tricky. This is a pityriasis rosea as well, but it's on a different, color-toned patient, so it looks a little different. Also, I did like this picture because it is more of classic pityriasis rosea that likes to show up on the board exams. It kind of spares the scapulas and goes down in a Christmas tree kind of pattern distribution. That's a very classic pityriasis rosea. Okay, treatment, you don't do anything, okay? So that's awesome. Really, the biggest thing in pediatrics, we reassure parents. So I spend a long time talking to each parent, like, it's gonna be okay, I promise. The biggest thing is that parents will call you back and say, it's not going away, Dr. Cope, because it takes about 3 months or more for this rash to fade away. So just keep reassuring, it's gonna be okay. They can put some like moisturizer on it, like preferably unscented, because that's not gonna flare eczema if they have underlying eczema. Some people can do like low-dose steroid ointments on there. I rarely do that because it generally doesn't itch that much, and it's really just the appearance that bothers the parents. Severe cases, if that happens, I really would encourage that you send them to dermatology for a second guess, and also if it is confirmed pityriasis rosea, then they can get UV light therapy there. Okay, this is one of my patients. So does anybody know what this rash is on the face? Does anybody have any questions? Okay, so this patient, I think she was like 9 years old, 9-year-old female, came in, I think the aunt brought her in and said that she started with one of those little white spots on her cheek, and then over the next 2 weeks, it kind of just spread all over her face, and they don't know what it is. And she also went to school, and they had her separated from her peers. She wasn't allowed to touch anybody. Nobody was allowed to touch her, and she had to stay like really confined in the classroom. So it was a little sad, but okay. So I can kind of describe it to you. So she's kind of got really well-defined, kind of lighter patches on her skin. It's hypopigmented, it's not depigmented. There's a little bit, it's dry kind of feeling, and she's got some crusting around the rash. So I can tell you what I did. I messed up on this rash, so that's why I thought I'd present it. I thought it was tinea facies, right? So I gave her a topical antifungal cream, and I just felt in my gut that it wasn't right, but I went ahead and treated it because when I was doing my differential, that this rash mostly looked like tinea facies, so I treated it as such. A week later, the parent called back and said, "It's not going away, Dr. Cope," and I said, okay, let me go back to my differential. I had also happened to ask the patient, does she have a history of eczema? Because nummular eczema can also look like this. It also kind of looks like pityriasis alba, which I'm going to show you more pictures in just a second. So I kind of went to number 2, which was eczema. She also had a history of asthma that I happened to ask, but not a history of eczema. So when she called back a week later, I gave her a low-potency steroid ointment, and it went away. So this is actually nummular eczema. So tricky. All right, this is tinea. So this is what I thought it was. Tinea facies looks very, very similar. And here's the difference, right? So on your right-hand side, that is nummular eczema. The big key is that with nummular eczema, you're not really going to have that central clearing in most cases. And it can be like a little scabby in the center and around the outside of it, versus tinea on your left-hand side, you can definitely see that central clearing and that red, thicker ring around it. So that will kind of help you. Eczema, I treat it every day, multiple times a day. So, the key features to kind of help you is that it itches. And back to that patient that I showed you, that was a key feature. They kept saying that she kept scratching, and I just ignored it, right, and treated it as tinea facies still. But that was a key feature because tinea doesn't really itch that much, but eczema does. And so it is very itchy, and actually they're scratching for the majority of the time. That's what causes the rash. So key feature, right, infants. So infants, when they present with eczema, they will typically have like pityriasis alba on their face, which is the lighter kind of patches on their face. It will be also dry within those lighter patches, and it's mostly on the face and sometimes like the abdomen, and you may see like a couple of spots on their arms. Versus older children, right, it's going to be in what I call your eczema hot spots. It's going to be in the antecubital fossas, the popliteal fossa, right, and then maybe some scattered eczema lesions. So just important to know those key features. Okay, clues to help. So if you look at a rash, you're like, I think it's eczema, but I'm not really sure. I've definitely been in that situation more than once. It may be helpful to think outside the box. Like for that one patient I showed you, she had a history of asthma. So if you have asthma, right, you're going to be at increased likelihood to also have eczema because it's that lovely triad that we see. So one of the associated features is what we call Denny-Morgan folds. And where's my pediatricians in here? This is on every board exam that we take. It's right, that allergic kid who has these kind of under eye circles. You can see they have a prominent skin folds underneath the eyelids. That's usually from rubbing, scratching. Right, dry skin, right? They're gonna have dry skin. That's what really eczema is. Lichenification, right? This is where the child is just chronically scratching, rubbing, because they have a lot of irritation in the area, and you get those type of skin changes, right? We all see this every day, keratosis pilaris. Very, very common. It's where we have keratin plugs on the back of our arms. I have a better picture on a slide in just a second. Pityriasis alba, that's right, you see these in the infants when they initially present with eczema, and older kids, it's just those hypopigmented patches on their cheeks. And ichthyosis vulgaris, that's where these like snake skin or those polygonal, patterns on their skin. And I just have them on each slide for you. And here's a better picture of the keratosis pleuris, right? We see these all the time. They usually are on the posterior aspect of their arms and their thighs, typically. Can also be on the cheeks, so. Okay, treatment for eczema. Number one, always hydration. So good emollient choices. For when I worked with inner city kids, it was going to be Vaseline unscented because it was the cheapest and it works really well. Aquaphor, Eucerin, kind of similar, same things. It's real important to tell parents to put it on. The best time to put it on is right after a bath because the moisture from the bath, when you apply the emollient on top, it really helps seal in the moisture and keeps their skin moisturized. Vaporizers, it puts moisture into the air, also helps put moisture into the skin. Also important to let parents know, like your fragrance, your Tide detergents that have fragrances in them, they can be irritating. So try to get them to stick to a Tide Free and Clear or something that doesn't have scents in them. Cotton clothing helps. Wet wrap therapy, right? Those are helpful. So when emollients don't work alone, we go to topical corticosteroids. So it is important. I have a potency chart on the slide coming up, but for young children, just kind of a rough ball, I usually always start with, or for infants or like face, I always start with a 1 or 2.5%. For older children, I usually don't start with hydrocortisone on their body first. I usually go ahead and go to a medium potency like a triamcinolone. Also helpful adjuncts, because eczema itches. It itches really bad. And so to control that inflammation, that chronic cycle, a lot of times we will do either like an antihistamine, something to control the itching with, especially at bedtime. I use hydroxyzine at bedtime. And then if we have a really bad flare for a kid, then I will use Zyrtec during the day just to give them some coverage during the day as well. And it's a little bit less sedating than hydroxyzine. So, okay, here's a potency chart. Other things, so when topical steroids, fail, what do we do? Eucrisa, Pacrolimus, kind of other non-steroidal options. Eucrisa, I use that a lot because Medicaid also pays for that now. If they failed steroids, I use that a lot. You can even use it on the face, right? So, because it's a non-steroid form. It's approved for 3 months and up, so. Okay, and then, just look for secondary infection because eczema can get infected. One thing I do want to also point out is breastfeeding. So if you have a high-risk patient, you see siblings, If a sibling has a history of eczema, allergies, you want to kind of coach that mom, try to maybe spend a little more time on her, encourage her to continue breastfeeding because it definitely shows that it helps. Okay, food allergies too. Okay, does anybody know what this rash is? Kind of running out of time here. I'm going to start going quickly. Okay, this is really common, This is just as normal, probably about 50% or more babies have them. It is nevus simplex, so it's just like your angel kisses, stork bite, Very common. You don't do anything with these, you just reassure, And it's parents tell the parents, yes, this rash will go away, it will fade with time, okay? It also gets redder when they get upset, If they're crying upset, it gets really, really red. This one looks very similar, but it's not the same thing. This is a port wine stain, or we also call it nevus flammis. These do not go away. Okay, so parents should not expect these to go away with time. They actually can get more redder and they can even come palpable later in life. So one thing I do want you to be aware with a port stain rash, if you have this patient has a rash in the V1, the ophthalmic nerve branch of the trigeminal nerve, if you have a port wine stain in that area, which I've definitely had patients with this rash in this area, they deserve a workup for Sturge-Weber. Sturge-Weber, you can have seizures, you can have glaucoma, so they deserve deserve an ophthalmologist referral, and they deserve a neurologist referral because a lot of them need MRIs. Okay, diaper rashes. Does anybody know what this diaper rash is? Oh, I told you. I'm sorry. I forgot. Yeah, so it is an irritant rash. So it's basically when the diaper's been left on too long, and they've had, irritating from diarrhea or, urine. So this is another diaper rash. This is, come on, where's my pediatrician back there? What is this? Yeast, thank you. Yes, this is yeast, okay? We treat them completely different. For contact dermatitis, right, you can, for contact dermatitis, it's different. The folds, or the inguinal folds, are spared. With yeast, it involves the inguinal folds, and then a lot of times you'll have what we call satellite lesions with yeast infection, and that kind of is the dead giveaway. We treat contact dermatitis with barrier cream, and I prefer a high zinc oxide content. That's just like your Desitin purple, or just Boudreaux's butt paste with the maximum strength. And then for the yeast infection, right, we do a topical antifungal. Okay, we're running out of time. Infectious rashes, right? Hand, foot, mouth disease, right? And then it can also mimic this, which is actually caused from parvo B19 virus. So that was the trick on that one. There's parvo right there, very common slap cheek disease or Fitz disease. And then about a couple weeks later, they'll have this big diffuse red rash that looks like a sunburn. This rash on the arm there is actually going away, so that you get that lacy reticulated rash when the rash is actually going away. So, but parents will come in when it's going away, because that's what panics them, is the appearance. Roseola, right? Okay, chickenpox. Okay, I want to real quickly. We'll finish on this one. This is chickenpox. Does anybody know what could mimic what this kind of looks like? A real common rash. So you have like vesicles, right? Some of them on this picture have bursted, so they kind of get like a crusting, and they all are at kind of different stages. I'm sorry? Impetigo, that's a good one. That's not the rash I picked, but yes. It is. So this is a patient. This is a patient that I had, unvaccinated, 2-year-old. You can look at his rash. I really thought he had chickenpox, and I worked him up as such. But all of his varicella titers, skin cultures were negative. So I went to number 2 in my differential. It was molluscum. So molluscum can also kind of look like chickenpox, because the kids will scratch them, they'll burst, and you'll start getting a crusting as well. So it's a trick, right? And that is the end of my lecture. All right.
All right. Our next presenter is Dr. Hannah Jones. Dr. Hannah Jones is board certified by the American Board of Internal Medicine and is a member of the American College of Gastroenterology, the American Society for Gastrointestinal Endoscopy, and the American Gastroenterological Association. She earned her bachelor's degree in biology from East Tennessee State University in 2009, a doctor of osteopathic medicine from LMU-DCOM, and a master of business administration from Lincoln Memorial University in 2014. She completed her residency in internal medicine and fellowship in gastroenterology at Baylor Scott & White Medical Center at Texas A&M University in Temple, Texas. Please help me welcome my fellow class of 2014 member, Dr. Hannah Jones.
Good afternoon. Happy to be here with y'all today. So today we're going to be talking about non-alcoholic fatty liver disease, something we're seeing a lot these days. Have no disclosures. So the objectives today, we're going to describe elements in the progression from non-alcoholic fatty liver disease to non-alcoholic steatohepatitis to cirrhosis. Describe risk factors that should prompt an evaluation for fatty liver disease. describe methods to assess fibrosis and the associated implications, and understand the management of fatty liver disease. So it's a spectrum of disease activity. First you get steatosis, which is basically fatty deposits in the liver, and then the fat sits there long enough, it starts to stir up inflammation, which results in steatohepatitis, and that leads to scarring, fibrosis, and can lead to cirrhosis. It's increasing in prevalence. We're seeing a lot more obesity, insulin resistance, dyslipidemia, about 30% of the population in the United States, and most people are asymptomatic. It's a leading cause for liver transplant in women and those over 65. So you have lots of things that can cause steatosis in the liver. You have alcohol, non-alcohol, but today we're going to focus on the non-alcohol because we do see a lot of that. You do want to remember those secondary causes like medications, TPN, and other medical conditions that can result in steatosis and not just be from the metabolic comorbidities. So steatohepatitis is basically just diffuse inflammatory changes in the liver. You start to see cellular ballooning and damage, and that's when you start to see little elevations in the AST and the ALT. So anytime I see that, I run a full panel on them, a serologic panel, to make sure that there's nothing else going on. So I think it's very important when that happens to get that checked out, refer to GI, make sure that it is just fatty liver and not another cause, because it's pretty common to have someone come in, you can have more than one thing. They have had autoimmune hepatitis for quite some time in addition to some fat in the liver or, alcohol and that. So there's lots of other things that can happen, and it's important to exclude those things. Ultrasound is a good first start to look into anything elevated liver enzyme related. And then typically, even if it is fatty liver, even without elevation of the enzymes, I go ahead and assess for immunity for hepatitis A and B just to help prevent any further damage to the liver, assess and see if they need to be vaccinated for those things. So you want to screen at-risk populations in primary care, so people who have diabetes, people with obesity, metabolic syndrome, family history of cirrhosis. So the big thing with fatty liver disease is there or is there not fibrosis, because that's what's going to ultimately change your management in those patients. So you want to assess if there's a little bit of fibrosis, if it looks like it's already cirrhosis, or what's going on there. So it's stage 0 to stage 4. So stage F2 or higher puts you at risk for issues related to that. Then stage 3, that's when you want to really start considering screening these people routinely for HCC. And then F4, that's going to be your cirrhosis patients, and then they get to come see you every 6 months for labs, imaging, and you really have to monitor them closely for progression of disease. They recommend complete abstinence from alcohol with F2 or higher, but honestly, anyone that I have with the liver disease, I tell them you don't want to do anything to add flame to that fire, so just try to avoid that if at all possible. This is kind of a busy slide. It's from the AASLD guideline, which was just updated recently. It's an excellent resource for all this information. Basically, it is highlighting how to identify those who are at risk for developing fibrosis and progression of fibrosis to cirrhosis, and focusing on when you should refer them to GI. Like I said before, if you have somebody with elevated transaminases and it's not something obvious or doesn't make sense, then that would be when I would recommend just getting it checked out to make sure there isn't something else going on. But the FIB-4 is what they recommend. It's a calculation that I'll get to a little more detail here in a second, but it's something you can calculate with just basic information, some basic labs, age, things like that, and it just, the levels can determine there when you should refer. So when we're talking about fibrosis, we really prefer non-invasive testing. Liver biopsy obviously is the gold standard, but we tend to not do that unless we have a reason to do it, if it's going to change management. So the FIB-4, like I said, you can calculate that using age, AST, ALT, and the platelet count. You can go online and find the calculators for it. It is statistically inferior to other methods, but 90% sensitivity for cirrhosis, so it's really good at picking up really bad fibrosis, but we hope to catch it before that. One of the non-invasive ways to catch it is vibration-controlled transient elastography. So basically you're measuring how stiff the liver is. It does have some limitations, because if you're doing one like FibroScan, basically the distance from the liver to the skin can affect whether or not they're able to do that study or do it adequately. Pretty good sensitivity and specificity for that. We also have ultrasound elastography available in this area, and that one's a good one too that's helpful. MRE, so magnetic resonance elastography, is the most accurate non-invasive marker. It's more sensitive than the transient elastography, but it's not a first-line method. It's not as widely available, and obviously it's going to be a little bit more expensive than the other tests. So risk factors: poor progression, age over 45, BMI over 30, postmenopausal women, diabetes, and then if they have hepatitis C in addition to that. So the treatment, obviously healthy diet. Some people recommend Mediterranean, which is basically a hypocaloric diet. You want to limit your red processed meat, fructose, and things like that, the sodas, regular exercise, and then you want to try to manage all of the metabolic comorbidities that have contributed to the fatty deposition in the liver. So you really need, when you're talking about weight loss, to get at least 5% to start to see any improvement, but 10% is what you need to actually get the fat to start pulling out of the liver and actually improving that inflammation. So you want to consider bariatric surgery for those with BMI over 40 or over 35 if they have metabolic comorbidities, which a lot of them do. As far as medications, there are no FDA-approved pharmacologic treatments specifically for the treatment of fatty liver disease. There are some trials out there with vitamin E, and you can consider that for people who have do not have diabetes or cirrhosis, and that's only for people who have had biopsy-proven steatohepatitis. So they've had to have significant workup. It has shown in that population some evidence of reduced inflammation, some lower rates of decompensated issues over time, but no significant fibrosis reduction. And then there are a lot of studies out there showing the risk of hemorrhagic stroke and of prostate cancer. So you want to use that very cautiously if you decide to use that at all in the patient population. We do not recommend milk thistle. I have patients come in quite frequently who have started themselves on milk thistle, and we have to have that conversation, but that's a very common one that I see, but it's not recommended. It is okay to use semaglutide or pioglitazone for appropriate indications in that setting, and then coffee. That's one of the things that's fairly easy to do if they have no contraindication. 3 or more cups daily is associated with less advanced liver disease, basically slows the scarring and fibrosis, and that is just straight coffee, not coffee with creamer, coffee with a bunch of sugar, just plain coffee. That's what you need to do that, because obviously the other things kind of outweigh the effect. Statins are recommended for dyslipidemia, and having non-alcoholic fatty liver disease or steatohepatitis does not increase the risk of liver injury from statins. So if they have this and they do have a little minor elevation of their transaminases, it's still okay to start them on that statin. It is okay in the setting of compensated cirrhosis, but you have to be cautious with that, and then you really want to steer away from it in decompensated disease. The big thing here is that cardiovascular disease is the #1 cause of death in these patients, so it's very, very important to get the dyslipidemia under control. So don't worry about it if they have a mild elevation in their transaminases. All right, I have a few questions here just to kind of go over some of the highlights. So 45-year-old male with non-alcoholic fatty liver disease, hyperlipidemia, sleep apnea, and hypertension has been following a Mediterranean diet, engaging in a routine exercise program in an effort to lose weight. His BMI is 38. He's been compliant with his statin therapy, antihypertensive medication, and his CPAP, but despite his best efforts, has been able to lose less than 5% of his body weight. So what would be the most appropriate recommendation for this gentleman? So that one's going to be B. You want to go ahead and refer him for bariatric surgery because of his comorbidities and BMI. And obviously, he's really trying to do all the right things, and it's still not getting him there. So to really show improvement, that's going to be his best option. Then you have a 50-year-old female who presents to established care with you. She has several medical conditions, including obesity, hypertension, hyperlipidemia, type 2 diabetes, routine labs with mild elevation of her transaminases with AST of 65, ALT of 70. What would be the next step for her? So based on the ASLD guideline, they would say it would be C to calculate the FIB-4. Honestly, that's not something that I use in my practice. I think at that point it would be reasonable to refer to GI or get an ultrasound and refer to GI or just assess it that way. But based on the guideline, they would recommend that you use that calculation to try to determine if they're high risk for fibrosis or not. So I think any of those things would be acceptable to do. Okay, last one, a 60-year-old male with biopsy-proven non-alcoholic steatohepatitis presents for follow-up. He is exercising and has made dietary changes, but weight has remained stable. Diabetes is well controlled on current medication. Labs demonstrate normal CBC, AST 50, ALT 55, persistent hyperlipidemia, and A1C is good. What is your recommendation? So this one's going to be B. It's just highlighting the importance of making sure they're on statins, even if they have a mild elevation of their transaminases. That's not something that I would worry about initiating a statin therapy with. Obviously, if you initiate statin therapy and then their transaminases increase 3 times upper limit of normal, then that would be a concern. But most of the time, they tolerate it without any issue. So, and there are my references. So, does anybody have any questions?
Which laboratory testing would be your number one choice when it comes to FibroScore?
I use the FibroSure
FibroSure.
primarily because it's easy to access where I practice. I run that pretty frequently. None of the blood-based tests are as good as the imaging-based tests. So pretty much the result of the imaging-based test, if you get a FibroScan test or the ultrasound elastography, those tests are going to trump the result of the blood test. But I think that it is helpful if you're going to go ahead and get a panel of labs to go ahead and get that test. So in this area, I know the FibroSure is the one that's easiest to get.
I didn't know there was a new 2023 guideline. It seemed like the trend had been sparing the pioglitazone for patients with NAFLD plus diabetes. Is there any change to where we're being a little bit more lenient and aggressive with pioglitazone or even semaglutide in patients that have NAFLD without diabetes, or can you comment on that or some nuance there, the trend in the specialty?
Yeah, the trend with even the updated guideline is that they only recommend the use in patients who have an indication to use, not just for fatty liver disease. They also, basically if you're trying to treat their diabetes, yeah, go ahead and use these. These drugs are going to be better and more helpful, but in the absence of it, yeah, there's not really been a huge change in the trend of that.
Thank you.
Any other questions? We had one question for Dr. Cope that came in online. And the question was, is there anything to watch out for in regards to the side effects from Eucrisa?
Yeah, that's a great question. So with Eucrisa, the side effect profile is actually pretty good. The only really side effect that I'm aware of is if you're actually allergic to the Eucrisa. I have clinically never seen any patient allergic to Eucrisa, but that would be if they developed like redness and like hives in the area that they applied it. I would also go a little bit further too. It's a common, not allergic side effect, but a common side effect that patients will experience with Eucrisa burning when they first apply it, especially if they have breaks in the skin. So I usually tell parents too, they may have some burning, they may say it hurts, and that is normal and that's common. You can still continue to use it. So, okay.
Any other questions for Dr. Cope or Dr. Jones? All right, we'll take about a 10-minute break and restart. think it's that one to advance, and I think that one's the one to go back. And then I think there's a laser pointer too. You need to. There you go. Do what? All right. We'll go ahead and resume. Dr. Mark Ansel Peacock is our next presenter. Dr. Peacock is a family medicine physician at Farragut Family Practice in Knoxville, Tennessee. He graduated from Kentucky College of Osteopathic Medicine in 2017. Dr. Peacock went on to complete a traditional rotating internship in Lumberton, North Carolina, followed by his family medicine residency at Lake Cumberland Regional Hospital in Somerset, Kentucky, where he served as chief resident. He practices full-spectrum family medicine, including pediatrics and osteopathic manipulative medicine. Dr. Peacock has been able to fill a huge void in Knoxville by also providing inclusive care to the LGBTQ+ community. Outside of medicine, he spends time with his wife, Allison, and 2 dogs, hiking, kayaking, camping, and playing soccer. Please help me welcome Dr. Peacock. Thank you for being here.
Alrighty. This is a talk that I gave a lot when I was in residency. Being in that area of Kentucky, they didn't have a lot of care for the LGBT community, so I kind of came in and started that education process. So let's see. Not sure. There we go. Okay, so these are my learning objectives. Ultimately, to be able to understand the difference between gender, sex, and sexuality, being able to understand and make a diagnosis of gender identity disorder, being able to identify the risk factors of sexual minority women and men who have sex with men. Same thing with the individuals at risk for HIV, the basic understanding of PrEP, and to be able to identify a transgender patient and put into practice healthcare with appropriate screening. So I don't go into a lot of like HRT, so the hormones for transgender individuals. We can talk about that later if you'd like. This is more going to be preventative screening and like day-to-day stuff in the office as a provider. So the basics, so we'll just start with basic definitions. I like to use these. These actually come from the dictionary. So sex is essentially what comes as inherent by birth. So this is what determines you as male versus female, usually when it comes down to reproductive organs and structures. And then gender is your external factors. So this is behavioral, cultural, and psychological traits that are typically associated with sex. So when you think about what I call the alphabet mafia, the LGBTQIA+ community, there's a lot of different definitions. So L stands for lesbian. These are obviously women who are attracted to women. And first of all, these are all sexual identities for the most part. And then when you get down towards the end, we start to have just kind of more allies in different parts of the community. Gay is a man who primarily is attracted to other men. This can be a broad term used to describe everybody in the community, but typically it refers to the men. Bisexual is individuals who are attracted to both, genders. A transgender individual is a person whose gender identity did not correspond with the sex that they were assigned with at birth. The next T is transsexual, but you'll see I don't like it. This is an outdated term that some people still use. This really came from the medical and psychological communities when they were first diagnosing what a transgender individual was. Some people will still use it if they've had sexual reassignment surgery or some gender-affirming treatments, but usually this is outdated. There is an ICD-10 code for transsexualism, but I try to encourage people to avoid it and use more of the gender identity disorder ICD-10. Queer is a broad term. I'm trying to see it here. So it's an umbrella to just kind of identify a bunch of different people. So someone who doesn't necessarily identify as lesbian or gay, if they're pansexual, so they like all the different genders, that's down there at the end under P. So it's just kind of an umbrella term. Questioning, so people who don't know if they're in the community yet or not, still trying to figure out what their identity is. Intersex we will talk about, but these are people who are born with differences of sex development. And so we'll talk about what intersex is. Allies are everybody who supports the community. Asexual is more of a another, like a sexual identity or a sexual orientation. They're just not interested in anybody romantically, don't really feel sexual towards anybody. And then pansexual, again, they don't really have a preference whether it's gender or sex involved. This is my favorite depiction of what someone in the community can kind of be going through, especially a transgender. So this is a genderbread person. Notice it's not male or female. It's just a person. Gender identity is what's going to be in your brain. So this is how you identify yourself. So you can identify more on the female end of the spectrum or more on the male end of the spectrum or somewhere in the middle. But again, it's a spectrum, so you don't have to fall on one of the three categories. You can fall anywhere along that spectrum. Gender expression, that's what you're gonna wear. So you have more feminine clothing, more masculine clothing, more androgynous clothing. And again, this can differ from day to day. Your biological sex, it does have a spectrum line there. You know, obviously with karyotyping, you're gonna have more of the female karyotype, the male karyotype, but there is an intersex. And so we'll talk about a few of those processes in very, very small detail. But ultimately, you know, you may have external anatomy that doesn't match in the internal anatomy that you should have. You may have a bit of both. So that's where biological sex comes from. And then sexual orientation is who you love. So this is going to be, are you identified to the same gender that you identify as? Are you attracted to a different gender than you identify as? Or are you attracted to both? And again, all of these are spectrums. You don't have to fall all on the left or all on the right. It can differ from day to day, back and forth. This is another picture I like to use to kind of show how complicated that this can be. So it's not just two circles on the Venn diagram. You've got four involved. They're going to overlap, 12 to 16 times. So again, this is more or less to show how extensive kind of this community can be and how confusing it sometimes can be as well. So differences in sexual development. This is a group of diverse congenital conditions that affect sex differentiation, so also known as intersex disorders. They can affect sex chromosomes. They can affect internal reproductive structures and the external anatomy. And they can correspond with any gender identity, gender expression, sexual orientation, or sexual identity. So just because your chromosomes are one way doesn't mean you're going to feel or express the same way. Biological fact that a person's body, so this kind of goes with it, may not correlate with their behavior or identity. So some samples of intersex, you've probably heard of the 5-alpha reductase deficiency, androgen insensitivity syndrome, clitoromegaly, congenital adrenal hyperplasia, gonadal dysgenesis, Klinefelter syndrome is a big one that we've heard of. Turner syndrome's another one where they're born XO and not XX, but they're still identifying, or I guess they still present more as a female. So these are ones that can kind of complicate gender in general, or really sex in general. How common are these disorders? So this table comes from the Intersex Society of North America. So again, not XX or XY, so something like XXY Klinefelters, you're going to see at least 1 in 1,000 births. Androgen insensitivity, 1 in 1,300 births. So they're more common than you realize, especially like late onset adrenal hyperplasia that may affect people later on needing sex hormones and things like that. So a transgender person is someone whose gender identity and gender expression differ from what they're typically associated with. And so you'll see terms like FTM or MTF. This is female to male or male to female. And so these are ways that you can talk to your patients about how they identify or how they've transitioned. And then other terms, again, that we've seen, the transsexual that we talked about being the older term, and then transvestite, which is again, another old term that we try not to use. They're now kind of referred to as cross-dressers. These are people that are they usually identify as male or female, but then they gender express, they wear different clothing, but it's mainly more for entertainment, such as drag. So sometimes you'll have drag queens, drag kings, but that's kind of where that cross-dressing comes into. They do it more for entertainment, but not for a sexual purpose. So gender dysphoria is diagnosed by the DSM-5. So this starts with adolescents and adults. essentially they have to have at least 6 months, and they have to have 2 of the following. So they have to have a marked incongruence between how they express themselves and then with their primary and secondary characteristics. They have to have a strong desire to have or to get rid of their own primary, secondary sex characteristics, so like their puberty, things like that. A strong desire for the primary and or secondary characters of another gender, a strong desire to be the other gender, to be treated as the other gender, and then a conviction that their feelings and reactions, are active of that of the other gender. So again, 6 months, at least 2 of the following will give you that diagnosis of gender identity disorder. In children, it's kind of the same thing, but again, they can't vocalize things as well to us. And so usually you'll start to see them either vocalizing those, they might want to start picking clothes of the other gender. They may, when they play make-believe or fantasy, you see them playing the other roles. So, for example, someone who's assigned female at birth wants to be the dad or the uncle when they play house, or the brother. They'll start to pick their toys. They'll play games that are usually associated with the opposite gender. They'll want to play with other children of the other gender versus people of their same gender. They'll reject the toys of their assigned gender. They don't like their sexual anatomy. And then the strong desire for the physical characters that match one's gender expression. So, and I believe, and pediatricians can correct me, but usually by the age of 3 or 4, if you start asking a child what their gender is, they'll tell you, I'm a boy or I'm a girl. They can usually identify at that point. So when someone transitions, again, it's not going to be dependent on their physical appearance or medical procedures. Some people only socially transition, meaning they just change their gender expression, the clothing they wear. They may just tell their friends, hey, call me a different name, use different pronouns. Some people will go as far as legal transitioning, so that's when they get birth certificates changed, driver's licenses changed, Social Security. Some people may go on hormones, and so that's talking about testosterone, estrogen, and a lot of the other blockers. And then some, again, may have surgery, but some may do nothing at all. They just still identify, but they haven't pushed forward with any actual physical transition. So pronouns are a big one. So these are just kind of real basic pronouns. So she, her, hers, usually used with people who identify as female. He, him, his for male identifiers, and then they, them, theirs for people who are more non-binary, or say they're early in their transition and they don't want to be called the one that they were assigned at birth, so they just kind of go somewhere in the middle. And there's a lot of confusion when people are using they, them, theirs. They say, oh, that's a plural. How am I going to refer to one person as a plural? We do it all the time when we don't think about it. A patient will come talk to me and they'll say, well, I saw Dr. So-and-so for my heart today. Well, I just moved to Knoxville, so I don't know who they are. So I say, okay, well, what did they tell you? So that's the way that you can use a plural in the form of a singular. Zizai here is a very old, kind of more of a they, them, theirs. You don't see this a whole lot, but you might notice it more in a queer person who, they're trying to maybe be a little bit more different, but not necessarily. They don't identify as a they, them, theirs because it does fit into, these statistics here. But misgendering is a huge cause of anxiety and dysphoria in these individuals. And so even if you get it wrong, just correct yourself. When patients come in, whether you have it on your admission forms or in your chart, somewhere document if they have a different pronoun that they prefer, that way that you can use it that way. So then non-binary identities, we see this a lot. This has been a lot more common recently, but these are people who don't conform to the expected social standards. They kind of fit somewhere in between. So androgynous is probably the best term when you kind of look back in the day until now. These people identify as agender, so no gender at all. Bigender, they identify as both genders. Gender fluid, one day they may be more male, one day they may be more female. They'll change their gender expression on that day. They may even change their pronouns on that day. And then gender queer is kind of another umbrella term for all of it. So then for the non-binary person, when you think about medical interventions, some people will only use gender-affirming hormones for a short period of time to get a little bit more of that androgyny and then stop it. So you'll see people assigned male at birth go on estrogen, develop some breast tissue, and then they'll stop the hormone. Or you'll see someone assigned female at birth go on testosterone, get their voice to drop, get a little bit of facial hair, and then stop their hormone at that time. So, but again, they don't have to do anything either. Some will just do puberty blockers. There's a big spectrum on how you can do this, and that's why that's its own lecture at its own time. So part 2, this is kind of the meat and cheese of my presentation. But this is our role as a provider, what we're going to be doing on a daily basis in the office. So despite, all the progress that we're trying to make, essentially the experience that these patients are having hasn't been as good as it could have been. A lot of this comes just from unconscious or implicit bias that we talked about last year at this conference. Or just discriminatory acts that we're not necessarily realizing that we're doing. These patients also suffer from a large mental health disparity. Same thing with their physical health, and then they're more likely to participate in risk-taking behaviors. So we'll talk a little bit about those. So ultimately, medical education, whether it's in medical school or here at conferences, we just try to increase our awareness and knowledge so that we know where to target these people who are at risk. We can train students, again, providers as well, to provide these high quality care. And then we can also inspire, I say students, but anybody to just be advocates of the health, even if you may not necessarily understand it. Just we try to advocate for people to still get the health care that they need. So this is probably one of my favorite studies that I like to reference. This is an emergency department study that was done in JAMA, I believe, called the Equality Study. 70% or 77% of emergency department providers believe that patient would not disclose their sexual orientation if you ask them. They had that paternalistic kind of fear, like, I don't want to make anybody different, so I'm just not going to ask. When in reality, only 10% of the patients actually wouldn't tell you who they were sexually attracted to. And that 10% was mostly bisexual males. And that's kind of where that goes through. It's usually the bisexual males that were less likely to talk about who they were sexually oriented to. So moral of this story is ask everybody, because most people are going to tell you who they're attracted to. So these are just real basic steps to LGBT inclusiveness from the time they walk in your door. Educate your healthcare teams that they're aware of how to talk and discuss matters with these patients. Greet everyone traditionally, so instead of using their names or Mr. or Mrs., you can just say, well, hey, how are you? Welcome, things like that. Keeping your educational materials in your office inclusive, so not just having brochures, that may talk about one gender or the other, or having some LGBTQ stuff mixed in there, putting little stickers on your windows to kind of point out, hey, we recognize you, we're here. So again, avoiding binary language. If you don't know who someone's married to, saying you have a partner or a spouse versus, your husband or your wife. On your forms, if you can avoid using check boxes or providing an other option so that if they don't identify as male or female, they have options, or they can check off that they're female to male or male to female. That's one thing that Summit's done recently through Athena, was to try to add some more of those options. Asking blunt questions about sexual orientation to everybody, or sexual partners or sexual health to everyone, no matter their age or their gender. Asking the hard questions about, how do you prefer to be identified? What pronouns do you prefer? And then, would it change in what context? So if it's a younger patient and their parents in the room with them, try and, okay, I'll use this when you're alone, but when your parents here, I'll be better about using, what they know, type of thing. And then again, open-ended gender-neutral questions and terms. So there's just a couple examples of phrases that I use. I like to use the last one a lot. Are your partners sperm producing or non-sperm producing? That way you're not assuming someone's gender. So if their partner's assigned male at birth but they identify as female, they're still sperm producing, and so knowing that may help target some risks. I will say it does confuse some women whose assigned male at birth partner has had a vasectomy, because there's no sperm that comes out, so they start to think that they don't produce sperm. So you may have to, if they seem confused, you may have to kind of change the question a little bit. So we'll start with the care of sexually minority women. So you'll see a lot of the SMW used a lot, so I didn't have to type it out each time. But these are lesbian, bisexual, and transgender women. When I say transgender women, I'm referring to someone assigned male at birth, transitioning over to a woman. So there can also be racial and ethnic minorities that are involved. So people who are, a person of color, even Asian cultures, they're also sexual minority women. So in a study done in 2013, 1.3% of women identified as homosexual, gay, or lesbian, but 17.4% of women actually reported sexual activity with someone who was the same sex as them, whether it was just a single experience or more frequent encounters. Biggest barrier to healthcare for them, they're less likely to have health insurance. Now, this is getting better now that we're seeing marriage being recognized in most states, I guess all the states here now in the United States. But before they, if they were someone long-term, they couldn't get access to their partner's health care because they weren't married. So that was a little bit harder. Lower income family, obviously when you have two women, they're less likely to make the same amount of money as men. And so that income can make it difficult. And then they're also less likely to take advantage of family planning clinics because when you start to go to a Planned Parenthood, then you have to worry about protesters and things like that, making it difficult just to get normal primary care. They're also more likely to have a judgmental or insensitive encounter with the healthcare provider, and that means they're less likely to keep their follow-up appointments. There's also the assumption of heterosexuality. So this happens a lot. You don't ask who people are sleeping with, and so you're missing a lot of things that need to be screened for. And then again, higher risk for mood disorders, higher risk sexual behavior, substance use, abuse, and suicide. And so a lot of this can be missed if we don't ask. Mental health, ultimately with stigmatization, non-acceptance, that's going to lead to more depression, suicide, anxiety. So ask about their support networks. Who in your family, is supporting you, what friends, what chosen family do you have, things like that. Identify the people who aren't supportive and try to figure out where you can help bridge the gap maybe. These patients are more likely to misuse, substances, so alcohol and drugs. And then obesity, they're actually 20% higher, 20% more likely to be obese than their heterosexual counterparts. Stress, alcohol use are important to emphasize. Again, with their mental health, they're more likely to turn to substances. And then intimate partner violence is huge. 61% of bisexual women are more likely to be abused by their partner. 44% of lesbian women, and then versus 35% of heterosexual women. And ultimately, when you see two women in a relationship, if one woman hits another woman, they're not going to really report it because it's not a man hitting me, it's a girl, it's okay. But that's one thing that we see a lot in the sexual minority women is more likely to be abused. Let's see, so sexually transmitted infections. Let's see, did I miss one? Oh, sorry, I missed this screening, the cancer screening. So this is the one that I want to talk about too. So cancer screening and prevention. Breast cancer, this is likely attributed to their obesity, their nulliparous status, and their alcohol use, which is going to increase their risk for breast cancers. So make sure that you're doing your mammograms, their family history, things like that. With cervical cancer, again, less likely to have health insurance, so not going to go in for their routine pap smears. The negative experiences that we briefly touched about, or even beliefs that paps aren't needed when they're not sleeping with men. But I think one of the recent studies I was reading was that HPV was found in 19% of women who've never had a sexual contact with a male partner. So make sure that we're trying to get them in for their pap smears, doing their yearly pelvic exams. And then with the ovarian cancer, again, this is also increased to nulliparity, so not all partners are going to carry a pregnancy. They're not using hormone OCPs or hormonal contraceptives because, again, their partner can't get them pregnant. So that's actually increasing the risk for ovarian cancers. And then just there's no formal prevention for ovarian cancer. So if they're already not coming in for their routine, pelvic exams, now we're missing times to screen and ask them questions about their pelvic health. So now moving on to the sexually transmitted infections, it's important to remember that these people are still at risk. Usually in these sexual minority women or women that have sex with women, we're seeing trichomoniasis is huge, HIV is still a possibility, HPV, HSV, Hep C, syphilis, chlamydia, and even bacterial vaginosis has been shown to spread from partner to partner. Sexual toy use actually has a higher risk of infection than penile sex, maybe due to lack of, cleaning between partners, things like that, not using condoms on their toys. That's one thing that can increase that risk. So risk factors, and this is going to be important when we talk about the men who have sex with men later in the presentation. Risk factors are they having a new partner in the past 60 days, multiple sex partner, or a partner who has multiple sex partners, none or no inconsistent condom use with their item, their penetrative items, outside of someone who's mutually monogamous. Again, with their mental health, trading sex for money or drugs. Sexual contact, so with sex workers, meeting anonymous sex partners on the internet, young age, history of prior STI, a lower socioeconomic status, high school education or less, incarceration of some sort, and illicit drug use. Now, you see this and you're like, well, that makes sense, right, for straight people as well. So these are just something that we need to kind of remember, solidify in our head. Because it's going to pertain to really anybody. That's what's going to make them higher risk. Let's see. And then before we move on to that part, just to touch on real quick, ways that we can prevent STD transmission, obviously, is education. We can talk about the appropriate vaccinations. So hepatitis A, hepatitis B, HPV vaccines, which are now approved to age 45. Trying to get it before 26 or before they're sexually active, but you can vaccinate later, especially if they have a sexual partner change. We'll talk about it in the men who have sex with men, but discussing PrEP or pre-exposure prophylaxis against HIV. I see this a lot in the transgender women who still have partner that are men, and so that also increases their risk for HIV. Valtrex has HSV suppression if they're known to be a carrier. And then barrier methods, of course. So as far as physical exam, it should be the exact same as your non-sexual minority woman. Staying alert for signs of physical or emotional discomfort. Again, they might not feel comfortable coming to the doctor. Remember that they have a higher risk of trauma or abuse, and so looking for any signs of abuse, bruises, lacerations, burn marks, things like that. And then determine if pelvic exams are needed. For trans men, I did throw them in right here. So a trans man is someone who was born female, and I transitioned over to male, or non-binary individuals. When you're doing the exam, asking them, do you have a term that I use so I don't say a term that's going to make you feel uncomfortable? Gender-neutral language, such as genital exam versus vaginal exam. So just trying to be a little bit more conscious about the words that you're using. If you talk to OBGYNs, I think there's a mixed field. Some are still doing pelvic exams every single year. Some are doing them only with pap smears every 3 to 5 years. It's really just determining their risk and then symptomology and then going from there. Reproductive health and parenting issues. This is really big when there's two women in the relationship. Obviously, it's a little bit harder to get pregnant naturally. And so talking with the partner, making sure that their partner is involved in these conversations. With societal and financial issues, again, they run into obstacles when they try to fulfill their desire to becoming a pregnant, whether it's a homophobic stigmatization, potential rejection by their families. They also may have limited access, finances, the availability for resource at sperm banks or insurance coverage. So I think the average vial of sperm is about $5,000 per vial, and it can take 1 to 2 vials per insemination round. So they can get really, really expensive. As far as parenting options, you could do fertility services such as IUI or IVF. Patients can even elect fertility treatment for one partner. Some will do both partners, which is called reciprocal IVF. You take the egg from one partner and you inseminate it and then implant it into the uterus of the other partner so that they both feel a connection. But there's also legal concerns when you use a sperm donor, trying to make sure they don't have any legal rights to the child. And then with the non-biological same-sex partner, talking about adoptions and things like that. So they may ask you, what steps do I need to take? And so just being a little bit more educated about the different processes may help. I know in Knoxville, they do recommend a second parent adoption or a confirmation adoption, even if you're using a non-known donor. And then obviously adoption and foster parenting would be really huge to help them pursue parenting. So now switching over to men who have sex with men. Obviously gay is that term that is generally used to describe this community. But it's more, so I guess, so gay is the term that's used, but then men who have sex with men identifies the behavior, so bisexual male. 3.5% of the population usually identify as gay or bisexual, but 8% engage in same-sex activity. So again, just because you identify one way doesn't mean you may not engage in the activity. 11% of males are actually attracted to the same sex, based on the 1948 study. I'm sure it's a little bit different now. So 2020 consensus, the biggest thing that these patients are at higher risk for, or have the disparities are going to be HIV treatment, prevention, infectious diseases, STIs, immunizations, cancers, substance tobacco use, behavioral health, mental health disorders, and then again, intimate partner violence. So with HIV, between 2010 and 2019, we actually saw a decrease in HIV diagnosis, probably because of PrEP coming out. New infections were actually decreasing in white men who have sex with men, but amongst people of color, so African American or Latino, we're actually seeing no change in their new infection rate. And we're also seeing a high incidence in black men who have sex with men. But again, this is probably related to some racial inequality, lack of access to prevention services, lack of awareness of their HIV status, delayed recognition, etc. In CDC statistics are showing about 69% of new cases where men who have sex with men who also inject drugs. So they're also now having these higher, risks that are going to put them at risk to have sex when their inhibitions are lowered, if that would make sense. They're less likely to use condoms. The highest prevalence of HIV is actually found among transgender women. So again, these are women who were born male and then transitioned to female. So what can we do to prevent HIV? Obviously, universal screening at least once per year, even in monogamous couples. And then more often if they're taking PrEP, which is the pre-exposure prophylaxis, or higher risk behaviors. So typically someone who comes in and wants to be on PrEP, they'll be seen every 3 months and they'll have STD testing every 3 months. Talking to them about how to choose their partner, so what's called serosorting. So essentially you try to only have sex with a partner who has the same status as you. Seropositioning, trying to choose sexual activities based on HIV status. So if one partner's, HIV positive, not having them, in a vulnerable position, I guess, if that makes sense without going into too much detail. But you can actually maybe using oral sex versus penetrative sex, things like that. Consistent condom use at all times, discussing your HIV status with partners, treating HIV positive individuals, and then of course PrEP and PEP. So PrEP is pre-exposure prophylaxis and PEP is post-exposure prophylaxis. So pre-exposure prophylaxis is a daily oral drug that's most commonly used. There's a couple brand names out there. HIV and STI testing every 3 months is the typical routine. That's what my partner, Dr. Law, and I do at our office. There is a newer long-acting injectable as of 2022. You get a loading dose 1 month apart, so 2 doses 1 month apart, and then they get a routine dose every 2 months, but they should still come in every 3 months for their STI testing. This continues to still be studied in men who have sex with men, adolescents, cisgender women, transgender women, and then serodiscordant heterosexual couples. So one partner has HIV and one does not. Effectiveness really relies on adherence. The more likely that you are to take your medicine, the more likely you are to not contract HIV. When it's used appropriate, it's greater than 99% effective. So the two main branded drugs on the market can both be used in assigned male at birth, but only one can be used in assigned female at birth. And then as far as post-exposure prophylaxis, that's typically the tenofovir and I can't say that one, sorry, but that is one that can be used in assigned females at birth, plus raltegravir. This must be started within 72 hours, and they take it daily for 28 days, and if they wish to come off it at that time, they can. So with STIs, so the risk factors as we discussed earlier are the exact same. So we again discuss these about risk reduction, trying to talk about safe sexual practices with your patients. Minimal risk of HIV transition is usually associated with oral sex, but not syphilis, herpes, or chlamydia. So those are still just as prevalent with oral sex alone. Since they have higher risk of chlamydia and gonorrhea, we can actually consider what's called doxypep, which is a post-exposure prophylaxis with 1 dose of 200 milligrams of doxycycline within 72 hours of that sexual contact. So that's one that's kind of come out in the last couple of years as well. So also, again, minimum yearly screening for all sexually active men who have sex with men, unless they're in long-term mutually monogamous, HIV concordant relationships. There's always an if. Syphilis, genital chlamydia, and gonorrhea, rectal chlamydia and gonorrhea, and oral pharyngeal should also be tested in these patients. And then more frequently, like I said earlier, if you're on PrEP. I'm not sure if I mentioned it later, but doing rectal paps are a thing. You just have the patient swab their rectum themselves, and so making sure they don't have HPV, but then also the rectal chlamydia and gonorrhea. So immunizations in this population would be hepatitis A and B vaccines are huge. I try to check hepatitis B before I start PrEP. And if they're immunized, I go ahead and start talking about the immunizations at their next follow-ups. HPV vaccines, again, up to the age of 45. Monkeypox was recently new, so talking about getting vaccinated there, and I believe they just discussed a new booster. And then the meningitis vaccines as well, especially for patients who have HIV. Cancer screenings in these patients, they do have higher risk of anal carcinomas, so make sure that they're doing their rectal paps, at least screening for HPV once per year per the rectum, doing their colonoscopies, and then oral pharyngeal cancers likely related to HPV infections. So make sure that they're getting routine exams with you, and then dental care as well. As far as substance and tobacco use, again, smoking is actually more common in gay men versus heterosexual men, so now we have higher risks of different cancers. Alcohol use disorders are also going to be higher. There is no increased use in illegal drug use among gay men, but they're more likely to use alcohol, marijuana, and hallucinogens, whereas in heterosexual men, cocaine, prescription medications, and methamphetamines are more likely to be used. So I think the biggest thing when it comes to substance and tobacco use is when they're under the influence or they're drunk, they're more likely to interact with another partner without taking the appropriate barrier methods. They're more likely to have that higher risk of HIV when they're using substances as well. As far as their behavioral and mental health, in 1973, homosexuality was declassified as a mental health disorder, which was huge, but we're still seeing higher rates of depression and anxiety disorders. I believe these men are 3 to 7 times more likely to have one or the other. Usually this happens as they start to realize their sexual orientation and their identity, and determining whether or not they were going to come out. Veterans in the community are also higher risk of PTSD, anxiety disorders, and suicide. Suicidal ideations and attempts are higher in gay youth, and they're more likely to experience body dysmorphia and eating disorders. Intimate partner violence is less likely to be reported in this community, mainly due to victim shaming and bias among officers. When you go to report your partner, there's really no screening or intervention recommendations, but just being aware of this statistic. We should always ask, do you feel safe at home when you're seeing the patient, solely? So then when it comes to our role as the PCP, when we're seeing a transgender individual, obviously we're going to be doing normal and secondary preventions. They may need help with medical documentation to get surgeries covered, helping navigate their insurance coverages for hormones and surgeries, and then referrals to different doctors as well. So that's kind of what we do, which seems pretty easy, right? As far as their office visits, when you're taking a history, you want to try to figure out what type of gender-related hormones or surgeries they've had or what they're planning on, because again, everybody's transition's a little bit different. What their reproductive history looks like if they're female to male. So asking about PCOS or hyperandrogenicity, that will increase risk of diabetes and obesity and things like that later. Family history of hormonal-related conditions, so breast cancers, prostate cancers, things like that. As far as venous thromboembolisms, cardiovascular disease, hypertriglyceridemia, breast cancer, prostate cancers, these are all going to be affected by the hormones that you may or not use. Sexual history, psychiatric history. Physical exams should be based on the organs that are present. So if they've had, if they're pre-op, then making sure that you're doing the appropriate exams there, and if they're post-op, still doing the exams based on their organs that are present. So if they don't have a uterus and a cervix anymore, there's no need for pap smears, but if they still have the vagina, then you should still do pelvic exams. And then as far as their lab tests, when they're trying to look at their hormone levels, it really should be based on the status of the hormone that's present. So a trans male, you want to see normal male testosterone levels and then lower estradiol levels, and then vice versa for trans women. And again, I don't go into all those details today. So physical changes that you're going to see when these individuals go on hormone therapy. So for a transgender woman, so male to female, you're going to see a feminine breast shape with underdeveloped nipples. Will have some fibrocystic changes if they've had any silicone injections. They may have minimal body hair or variable facial hair, depending on, again, are they having laser treatments? Their testicles may atrophy and come softer. They're also more likely to have an inguinal hernia because of tucking practices. So if you're not familiar with what tucking is, usually they take their testicles and they push them up towards the inguinal canal so that they're not hanging lower. Again, when we do this, they can't self-regulate their temperatures, and then more likely for testicular cancers. And then again, surgeries that these women may have are going to be bilateral orchiectomies, penectomies, a creation of a clitoris, neovagina, or even breast augmentation. Some may have facial feminization surgery, trachea shavings. There's a lot more that goes into transitioning into a woman. Whereas transgender males, you're going to see more beard growth, clitoromegaly, acne at first, but should level out, androgenic alopecia, so that male pattern baldness. And I was doing a little bit more reading, because they have two X chromosomes, and we always say it comes from your mom's side of the family. That's going to be the X chromosome that comes from mom. Well, now we have two of them, so you're more likely to have balding in these individuals. Rash and yeast infections under their breast if they're still binding and are pre-top surgery. So again, checking for those infections. And then their surgeries may include chest reconstruction with mastectomies, metoidoplasty, and phalloplasty. Metoidoplasty is really cutting the ligaments around the clitoris and then creating urethral lengthening through it some of the times, not all the time, so they can try to have penetration with their own organs, versus a full phalloplasty where they have to do some type of skin grafting to form the neophallus. So very big surgeries there as well. So screening and prevention in the transgender individual, if they're on no hormones, the same as their biological sex. For cardiovascular disease, they are at higher risk for morbidity and mortality, especially transgender women. When you want to go do your ASCVD risk calculator, you say, well, what gender do I pick? I usually say, pick the one that they were assigned with at first, what they were assigned with at birth, but I'll say you can't go wrong with picking the male status, just because that's going to give you a higher number when it comes to their risk when you're trying to determine statin use, or even just averaging the two. For diabetes mellitus, trans men with PCOS are obviously at higher risk. Trans women may have higher risk because of their insulin resistance, weight gain, and increased body fat that we see with estrogen. Higher risk of type 2 diabetes in trans people, when they were actually age matched with cisgender. And I'm not sure if that's due to the obesity or not from the hormones. Transgender women are more likely to have higher triglycerides, and transgender men, you're going to see lower HDLs and higher LDLs. As far as osteoporosis, trans patients after gonadectomy in a history of at least 5 years without hormone replacement regardless of age. So if they're compliant with their hormones, you can just usually start at the 65 or older. But if they've had gonadectomies and they're not taking hormones, then you want to screen within at least 5 years of that. And then after age 65, all transgender patients, which is kind of what I just mentioned. So transgender women, specific considerations would be breast cancer. If they're older than 50, their BMI is greater than 35, they're on hormone use at least 5 years, and a positive family history, go ahead and start doing mammograms. Cervical cancer screenings, obviously not necessary. They don't have any cervixes. But prostate cancer, if they still have their prostate, I would still look for it. But we are seeing a decrease in prostate cancer in this community, and they do have a higher risk of thromboembolism. In transgender men, if they have intact breasts, same thing for natal females, start at age 40. Mastectomy, your risk is now reduced, but they should still be doing chest wall exams and axillary exams every year in case some was left behind. As far as cervical cancer, if their cervix is intact, you still want to do pap smears on the recommended guidelines, but note that testosterone may affect your yield, so make sure that you're doing HPV screening on their pap smears. Their cervixes become very similar to that a female who's gone through menopause, so you may not get enough cells no matter how long you sit there and use, try to get a sample. But if they had a total hysterectomy, your guidelines are the same as a natal female. Obviously, there's a lot more. I really like the University of San Francisco transgender care website. So this is actually the link that's going to take you to the feminization hormones. But if you look at their sidebar, any question that you have, when do you start screening, what doses do I start patients on, you're going to find it on this website. But the big thing is, don't ever make assumptions about someone's sexual identity, orientation, or behavior. Just ask if they haven't put it on their paperwork if you're not sure. Knowing their identity, their orientation, their behavior is going to be really important to justify, or not justify their risk, but identify their risk. And screen everyone every time, even if you're not sure, just screen. And so this is me. Not sure. I think people who were here last year may have heard me announce that I was transgender, but this was me in medical school, and then me when I started my attending job. So I'm about 7 years now through my transition. This is a community that means a lot to me, so I'll keep doing what I need to. Any questions?
Any questions for Dr. Peacock? Check my phone. Or,
What do you do with the positive rectal or anal HPV? Like if there's nothing to see there and you just have a positive, what do you do with that?
Yeah, so I think what I would do, I haven't run into that yet, but what I would probably recommend is follow up with gastroenterology, whether they need to have just more frequent anal exams. Again, I'm not sure, there's really not a way to do a colposcopy, but doing different biopsies around the anal canal. But my best guess would be to get them over to gastroenterology to make sure there's nothing else that we need to do to help decrease that risk for it to change into a cancer.
And then why do you do annual HIV screening on monogamous, say, if it's a monogamous couple, why annual HIV screening?
Absolutely, because some partners won't tell you if they've strayed from the relationship. So,
But
yeah.
you also recommend it for straight couples too, right? If we don't do that.
Yeah, absolutely. I mean, there is that possibility because, how often does someone come in and say, well, I just found out that my partner has been cheating on me for the last, so many years. So you can always offer it annually, but you're right. If we're doing it in these couples, we should also recommend it in our cisgender heterosexual couples as well. But yeah, just discussing risks and things like that. So usually when I have, sexual health conversations with my patients, especially my cis hetero, I always say, just so you know, like if something changes, if you're worried about STDs, let me know, And a lot of them say, oh no, nothing's gonna change. And I say, well, I'm aware that nothing may change, but in case it does, I'm gonna be a safe space to talk to me, to talk about sexual health. I just try to talk about that with everybody regardless of age.
Anything else? All right, we'll take about a 10-minute break and then get restarted. All right, let's go ahead and get started. I have the privilege of introducing Dr. Michael Whiting. Dr. Michael Whiting is a Senior Associate Dean and Professor of PM&R and Osteopathic Manipulative Medicine at LMU-DCOM. Dr. Whiting received his Doctor of Osteopathic Medicine degree from Oklahoma State University Center for Health Sciences, College of Osteopathic Medicine, and his Master's of Education in Professional Medical Education and Educational Assessment from Central State University. Dr. Whiting completed a PM&R residency at the University of Minnesota Hospital and Clinics, and fellowships in sports medicine and electrodiagnostic medicine at Michigan State University, and a health policy fellowship at Ohio University, New York Institute of Technology. He is board certified in PM&R and sports medicine. Dr. Whiting is past president and board member of the Tennessee Board of Osteopathic Examination, and Dr. Whiting is also an International Olympic and Paralympic Games attending physician, and I consider him a mentor to me, and I would not be where I'm at today if not for his support of me. So please help me welcome Dr. Whiting.
Thank you. Can everybody hear me all right? Okay. It's great to be here. It's great to see y'all. Sometimes I use that expression. I was in a conference with the International Olympic Committee that I'm on, one of the committees I'm on, and I used the word, on this Zoom call. I said, well, it's good to see y'all. And one of the people said, so you people really do say that? It's not just in the movies. And I said, no, y'all's a real thing. It really is. So I'll probably fall into that a little bit. So I'm going to talk to you a little bit about the cardiac issues that we deal with in sports medicine. And so we'll look at some of the causes of cardiac issues in sports medicine, some of the epidemiology, how we prevent it, how do we recognize it, what's the pathophys, how do we assess it, and how do we treat it? And we'll look at what we know, and just as importantly, what we don't know, and where the literature really doesn't agree about some of these conditions. So I'm not highfalutin enough to have anything to disclose that's relevant to this presentation. So I think it's important we realize that people who engage in athletic activity on a regular basis do have structural changes to their heart, which can either be adaptive, normal physiologic changes, or they can lead to problems. And so sudden cardiac death is the thing that we're scared to death about, and it's usually from a heart rhythm change or a loss of cardiac function, oftentimes a conduction issue with athletes, and it's becoming more and more common. It really is. The estimated annual incidence of sudden cardiac death is 1 in 50,000. And that's up from the data that's about 4 years old. It used to be 1 in 50,000 to 1 in 2 to 300,000, but it's way closer to 1 in 50,000 now. And so it's really important that if we do any sort of sports medicine activity, that we're kind of familiar with what the risk factors are and who to screen maybe more closely, or who to even think about, do I need to screen somebody a little bit more closely? So as I said, structural heart changes occur with athletic activity. And again, they can be good or not. We know that muscle, like the heart muscle, like any other muscle, can get bigger if it's regularly exercised. We know that the ventricular walls get thicker, and we know that the ventricular chambers get larger. And we know that cardiac things like ejection fraction, those kind of things change and improve. Cardiac output changes and improves with regular athletic activity. The extent to sometimes how much these cardiac changes happen sometimes is due to conditioning, sometimes it's due to genetics, and sometimes it's due to the specific sport that's involved, whether it be an aerobic sport or a power sport or whatever. And so, for example, aerobic activities cause more of an increase in ventricular cavity size versus power sports that actually cause the ventricular wall to thicken more. When those changes are a bit asymmetric, that can lead to some output issues and make you more at risk for arrhythmic issues. ECGs can be very helpful in screening, particularly to show left ventricular hypertrophy, or if there's a QT interval issue, those kind of things, or any kind of sign of cardiac ischemia. There is some disagreement that I'll talk about later in the literature about who gets screened, who should be screened, and under what circumstances. There are some inherited channel issues, channelopathies, where the ECG can be absolutely normal. And then there are some genetic things having to do with mutations in cardiac sarcomeres, that kind of thing. So we'll plunge into this. Again, structural changes and abnormal cardiograms can make it difficult sometimes to differentiate between normal athletic heart changes versus something that could be potentially problematic. We know that left atrial enlargement is common in a normal active athlete in their heart. And we know it's also common in hypertrophic cardiomyopathy, which is a really common cause of sudden cardiac death. So there are some things that we can use to distinguish those things. One would be the absolute left ventricular cavity diastolic dimension. One can be family history, and that's why that very important American Heart Association recommendation for asking 14 key questions about cardiac history and health is particularly important, and then what their maximum oxygen uptake is. So cardiac disease in sports medicine can either be congenital, it can be acquired, it can be a rhythm problem, or it can be a structural problem. And we'll go through each one of those and look at each of the components of each one of those. Congenital or acquired ones are the most common. Hypertrophic cardiomyopathy is pretty much the most common one that we deal with, and it's basically left ventricular hypertrophy that's independent of anything else. Myocarditis is also part of that. It's typically due to inflammatory processes. Oftentimes it's mediated by different types of infections, and it can cause necrosis of the myocytes in the heart. You can have rhythm issues, and usually this is a conduction system issue where the rate or the rhythm or both can be interfered with, and that puts people at risk for ventricular arrhythmias, particularly as they get more and more physically active and as they change from one level of activity suddenly to a much higher level of activity. And of those, we typically will get channelopathies, and the most common ones of these would be the long QT syndrome, Brugada syndrome, and ARVC. You can have supraventricular tachycardias, and Wolff-Parkinson-White, we'll talk about that, and then commotio cordis, which has gotten some national publicity not too long ago. You may remember the case that was in the national news. And then we have structural or valvular issues. The most common valvular issue is with the mitral valve, and that would typically be mitral stenosis, or mitral valve prolapse, or mitral regurg. And then the other structural issue that it's not terribly common, but you sure don't want to miss it, is a coarctation of the aorta. So here are some pictures of some fairly famous athletes, some dating back into the 70s, the dark ages when I was in college, all of whom sustained hypertrophic cardiomyopathy and died on the court. One that I actually saw play live is this guy, Pete Maravich. I saw him a lot in New Orleans. I went to college in Louisiana, so we got to see him a lot, and that was a real tragedy. So hypertrophic cardiomyopathy, it is the most common genetic cardiovascular issue, and it's the most common cause of sudden cardiac death, as I said, in people under the age of 25, and it can be complicated by atrial fib as well. 40% of the athletes who have sudden cardiac death have this. The prevalence is there. The prevalence data is different depending upon whether we have studies based upon echoes that are done, or if the prevalence is based upon what their genetic history is, clinical diagnoses, their family history, that sort of thing. And this is one of the areas where the literature is a little bit different in terms of what people think should be the level of screening, like, for example, getting echoes, those kind of things, and we'll talk more about that. It's generally a genetically encoded mutation in some of the genes that cause the heart muscles to get disorganized and hypertrophied and change the size of the contractile filaments and to have fibrotic changes as well. And so the left ventricular walls get thicker, the left ventricular output changes as well, and you have these asymmetric changes that happen that decrease all of the functions of the left ventricle. And so what usually happens is that these changes are present for a long time, but they don't become evident until adolescence or early adulthood. It can happen anytime. I've seen it in athletes in their 50s and 60s, and I've seen it as young as 10, 11 years old. People can be completely asymptomatic, and the first knowledge anybody has that they have this is when they keel over and have sudden cardiac death. But we do know more now than we've ever known about how to, to proactively screen in, for example, pre-participation exams, and to figure out who needs additional screening beyond that. So here you have an illustration of, just hypertrophic cardiomyopathy. The main thing is just to notice that the ventricular walls are thickened all the way around, and in the septum between them, they're thickened as well. And this interferes with conduction as well. And then the mitral valve is intimately involved in this thickening, and it's compromised in the ways that I mentioned earlier. What you have here is some pathologic specimens. This is actually a pathologic specimen of a 17-year-old male athlete, soccer player, who fell over and dropped dead on the soccer court. What you see here is an MR scan, and what you see is the actual pathologic specimen here. So you see the very enlarged left ventricular walls, and the other thing you see is an aneurysm there as well that nobody knew that this kid had. Over here on the 12 lead, you can see inverted T waves up to V4, and you can see isolated premature ventricular beats here. And so this is kind of a situation that's very, very common associated with hypertrophic cardiomyopathy. And here you see diagrammatically, again, thick ventricular walls, and the EKG changes there, where you have altered QT intervals, and that EKG is very consistent with left ventricular hypertrophy. So hypertrophic cardiomyopathy, typically on physical exam, what we'll see is, and this is where you need to key in when you're examining these folks, not only for pre-participation exams, but also if they are symptomatic. You want to listen very carefully for a systolic murmur that normally starts right after the S1 sound. It's heard best at the apex and at the left sternal border. Or it could be a holosystolic murmur, loudest at the apex, and it typically radiates up into the axilla. Or it gets worse with Valsalva. So what I usually do when I'm examining these folks is I'll examine them for the murmur when they're sitting, and then I'll ask them to stand, and I'll ask them to squat all the way down, and I will ask them to stand up slowly, and I'll listen to their heart all the way up. And anything else I feel I need to do to make sure I'm hearing what I need to hear. Labs are not really very helpful. There's some genetic testing you can do, but it's probably not going to be readily available. You can do transthoracic echoes. You can do cardiovascular magnetic resonance studies, but those are, again, typically not all that available. Echoes certainly are, but then they're expensive, and there's different places in the world that have different rules and thoughts and standards about who gets an echo and when, under what circumstances. So we'll talk about that. From a prognosis standpoint, the mortality rate depends on whether or not people have it diagnosed before it causes them problems, if they have treatment or not. The later in life that it's diagnosed, the more likely they're going to have issues. Sudden cardiac death is more common in athletes over the age of 18, and not just athletes. It can happen in folks who are not athletes. There was a very famous case 3 or 4 years ago of a basketball official who actually fell over and he had hypertrophic cardiomyopathy. Nobody knew he did. And luckily, one of the basketball players on the team, it was a college game, actually was a CPR instructor, and luckily they had an AED there, and that happened actually here in Tennessee, and he made a full recovery. In some patients, there is some thought about, do they need to have a prophylactic implanted defibrillator? And we don't really recommend that for intensive sport activity unless after they survive this, unless there are issues where they don't do well, they're still symptomatic, or their post-event cardiac testing is not favorable in terms of results. So the other issue that we have in this category is myocarditis. We really don't know how often this happens in the general population. We know that college athletes who've had coronavirus have a rate, prevalence rather, of about 2.3%. We do know that the incidence of sudden cardiac death in people who have had acute myocarditis is significantly higher, and it's even more high in athletes who do very intense, long duration exercise, either related to training for their sport or the performance of their sport. We know oftentimes that there are pathogens that cause this. Most of the cases actually do clear on their own without any intervention, but if someone is immunocompromised or has other issues, then that may not be the case. There are several bacterial causes. Borrelia burgdorferi is number one. If you're taking a board question or something, that's going to be the answer that they're looking for. The most common viral one is Coxsackie virus, and there's some others as well that I have listed there. Cardiac disease can occur as a result of this. It can cause additional cardiac complications, and it can cause scarring, which makes people in the long run more at risk for a life-threatening arrhythmia and cardiac arrest. Typically, people will have the main event from whatever the issue is. It could be an infection or an immune issue or whatever. They typically will then recover from that, but they'll have that residual scarring, oftentimes with a dilated cardiomyopathy of some degree after their recovery is pretty much done. So on physical exam for these guys, the most common symptoms are fatigue and palpitations, precordial chest pain that you can't explain any other way, an intolerance to exercise that's unusual that you can't explain any other way, and just the kind of symptoms that you would see in somebody who had a viral syndrome. They just have muscle aches and maybe a little GI stuff, and they just don't feel well at all. You can check to see if their troponin is elevated. You can do a cardiogram, which is about 40% sensitive. And what you're looking for when you look for that is you're looking for prolonged QT, as well as QRS complex and or T-wave inversion. That's what you're looking for. In terms of treatment, when people have this, while the inflammation is active, we do not want them doing any really significantly active athletics, competitive or otherwise. We do want their exercise to be restricted, particularly if they have a viral cause of this. They're okay to return to play if their left ventricular function and their inflammatory markers are normalized. That's after they have a 12-lead cardiogram, after an echo, after exercise testing, after a 24-hour Holter, okay, and after appropriate blood studies, okay, and they've had restricted exercise for at least 3 months up to 6 months. After all of those, not a few of those, all of those, and so you want to make sure that you document that really, really well. If people have residual left ventricular dysfunction, ACE inhibitors sometimes can be used, beta agonists, and possible diuretics as well. So the next issue is rhythm issues. Primarily, these are going to be the long QT syndrome. It's the most common channelopathy. It's pretty common. Brugada syndrome. This is the thing that scares sports medicine docs and ER docs. We just do not want to miss this. And the prevalence is getting more, and when people get hyperthermic, the risk of this is even higher. ARVC's prevalence is getting higher. There's a greater risk in males than in females as well. And it's for, I like medical trivia. It's also more common in people who either are directly from or descended from the Veneto region of Italy, which is northeastern Italy bordering the Adriatic Sea. Some of my DCOM former students would be disappointed if I didn't come up with some little bit of trivia like that to just regale you with. But anyway, it is considered to be autosomal dominant. You have WPW. This is very common in children and young adults. It's more common 2 to 1 in males than females. And there's a high incidence of atrial fibrillation associated with WPW. And then we have commotio cordis. 95% of these folks are in fact males. There's a 26% overall survival rate that almost doubles if you can get within 3 minutes CPR and an AED. The predominance in the United States is greatest in softball and baseball, as well as lacrosse and football. And when I deal with international athletes, I'm more concerned about soccer players, cricket, and hockey. We don't really know what the official incidence is, but it makes sense in these particular sports because these are sports that are involved either with a projectile coming through the air that's going to hit the chest or something that they're getting hit with. It's amazing what you can legally do with a hockey stick to another human being. So what you have here is you have an athlete who's getting whacked with a hockey puck or a ball or something like that, or sometimes a fist. That happens in martial arts, or a foot as well. And the younger athletes who have more compliant chests are actually at higher risk. And so what happens at a very critical point right here, that's where the risk happens. It's the greatest risk happens. And so in the cardiac cycle. And so it's just a matter of if it happens at just the right or wrong, depending upon how you look at it, time, everything is great until the impact, and then kablam, and the patient goes into ventricular fibrillation. That's it. Boom. Commotio cordis. Not a good thing. So in terms of pathophys, for long QT syndrome, it's a channelopathy. It's genetically mediated, okay? Brugada syndrome is mutations in the sodium, potassium, and calcium channels, making it very more common to have a ventricular arrhythmia. Structural congenital abnormalities in the ventricles make Brugada more likely. Wolff-Parkinson-White, you have paroxysmal SVTs with pre-excitation ventricularly, which allows the electrical impulse to bypass the AV node. That's a problem, and this is highly associated also with hypertrophic cardiomyopathy and other congenital heart disease. So this is really important to get that cardiac history in your athlete. With ARVC, you typically get fatty infiltration in the right ventricle, and that causes ventricular hypertrophy on the right side, primarily because of issues with the calcium receptors interrupting the normal electrical signals. And then commotio cordis is basically, as I mentioned before, it's an acquired ventricular fibrillation from a direct blow to the chest, typically in the left chest, right at that upstroke of that T wave, right over the heart, usually from a projectile of some sort. And a lot of time these athletes are being told they have to wear, like a chest protector or whatever to decrease the likelihood of this happening. But the literature doesn't show that does anything except make all the rest of us adults feel better. It doesn't do anything in terms of helping out, in terms of preventing that particular problem. As far as disease course for long QT syndrome, Sometimes they will, if it lasts just a short time, if the abnormal rhythm lasts just a short time, people will be absolutely asymptomatic and they won't know they have it, you won't know they have it. But if it is symptomatic for a longer period of time, or if it lasts a little bit longer, they'll have dizziness and syncope, and that can lead to sudden death. For Brugada, they're typically going to have a syncopal episode and or sudden cardiac death. Wolff, Parkinson, White, again, they may not have any problems either in terms of symptoms unless it lasts for a long time and then it degenerates into ventricular fib, and of course they'll be very symptomatic when that happens. For ARVC, unfortunately, the first presentation of that is sudden cardiac death. So the key for that is just getting a really good family cardiac disease history. And for commotio cordis, again, you're not going to really be able to prevent it so much because it's just, you never know when that's going to happen. And if one of these people gets hit in the chest, it's only going to happen if they get hit at that very specific part of the cardiac cycle. And so the thing to always make sure you have when athletes are playing those, particularly those high-risk sports, is to make sure there's people around who know how to do CPR and you have an AED. That's really the key. So on physical exam for long QT syndrome, they're going to have, you want to check for palpitations as well. For WPW, they're going to have a tachyarrhythmia. Resting tachycardia is something that causes me to at least think about this when I'm doing pre-participation exam. If the person has resting tachycardia, this is always on my mind. It's not the most likely cause of resting tachycardia, but I always think of that. And I have a very low threshold to working that up. Brugada, as I said before, is asymptomatic until something bad happens. For ARVC, they're going to have a kind of a fluttering, pounding feeling in their chest, and they're going to feel lightheaded. And sometimes they'll have swelling in their belly and in their legs that you can't explain any other way. And again, commotio cordis, it just happens. So from a lab standpoint, there's not a whole lot you can do. You can get echoes up front, but here in the United States, it's really hard to get people who don't have a significant cardiac history or family history. It's hard to get an echo paid for. Our colleagues in Europe don't have that issue. If for long QT syndrome, if there's a family history of that, then you can get some genetic testing. In terms of cardiogram changes for the long QT syndrome, again, long QT, they're going to have a prolonged QT interval. For WPW, they're going to have a classic delta wave where the QRS complex is or upstroke is kind of slurred, and there's going to be a really short PR interval. I'll show you pictures of that. And then for Brugada, there's going to be a J wave, and that's in leads V1 through 3. And for ARVC, you're going to have epsilon waves after the QRS complex. So I'll show you those. So what you have here is, whoops, hold on, come back. There we go. What you have here, well, damn it, just a minute. Come back to me. All right, I'm going to try to hit the right thing this time. What we have here is the delta wave, okay? And so basically what you have is a very short PR interval, and this is WPW here. Over here you have, this is the epsilon wave in ARVC, all right? And then down here you have the J wave in Brugada syndrome, okay? So in these issues, what we do is if we can make the diagnosis of long QT syndrome, we can use long-acting beta agonists. We can, if they're at very high risk for sudden death, we can do an implantable defibrillator. Sometimes, in very severe cases, sometimes a left sympathetic denervation of the left side of the heart is done, particularly if they fail beta blockers and there's some reason you can't put in a defibrillator. Okay, for Brugada syndrome, they should not do competitive sport once if they're symptomatic at all. They're at very high risk for ventricular fibrillation. Okay, sometimes ablation is a last resort. WPW, you can ablate the aberrant pathways. That's done fairly often, and these guys can't do competitive sport if they have high risk. Any extra risk factors. ARVC, we typically treat those with beta blockers and other antiarrhythmics, ACE inhibitors, that kind of thing. And then for commotio cordis, again, really primary prevention. There's a move to have some of the balls that are used in some of the sports be a little bit softer. But if they have, if a person has an underlying cardiac disease that's playing a sport that's highly associated with commotio cordis, as uncommon as it is, there are some who advocate in the literature that you do place an implantable defibrillator for prevention, primary prevention. The secondary prevention is the thing that most commonly happens, and that's where you make sure you have an AED available and try to wear chest protection garments. Sometimes that's better for maybe a legal protection for a healthcare, for like a school system or something like that. But again, the literature doesn't really show that those, there aren't any good studies that show that those are very helpful at all. From a structural disease standpoint, we have primarily issues with the mitral valve, okay? Mitral valve prolapse, which is typically a connective tissue or collagen issue with the valve leaflets. These are highly associated with things like Ehlers-Danlos, Marfan's, osteogenesis imperfecta. And so, the valve basically bulges back into the left atrium in the systolic phase. There's some other genetic and other issues that can cause that, but that's the most common one. It can happen as a result of compromised cardiac function after an infection in some kinds of autoimmune diseases as well. And if people have endocarditis, that can be a sequelae of that or a complication of it. Or if they've had any kind of an embolic event. The mitral valve prolapse is twice as common in women as men. Mitral regurg, this is where the valve doesn't close completely, allowing blood to leak back into the left atrium. It's commonly found in people who have rheumatic heart disease of all different kinds, as well as people who have coronary artery disease and significant history of coronary artery disease. It is the most common valvular abnormality in the world. Okay, so it's not rare. You need to be thinking of that when you're listening to the heart. And as you get older, the prevalence gets higher. Mitral stenosis is where the valve narrows down, reduces blood flow into the left ventricle. It's more common we see it a lot more in developed countries. It can be complicated by atrial fib. Mitral stenosis and regurg can also lead to pulmonary hypertension, so that's another issue. And then we have coarctation of the aorta. This is where you have a segment of the aorta that's constricted. It's either a very small constriction or a long constriction, can be either way. Typically it's in the thoracic aorta, but it can actually happen in the arch of the aorta as well. Much more common in males. And we see this from primarily in pre-adolescents and adolescents and young adults up to about age 30. This is one of the reasons why on the pre-participation physical exam, one of the things that you have to do is to check simultaneous radial and femoral pulses, because there'll be an asymmetry between those two because of the coarctation. So here we have mitral valve prolapse, where the shutters of the valve kind of sag, and you can get blood going back where it's not supposed to be. For mitral regurg, it goes back where it's not supposed to be. And then for stenosis, it's very narrow, okay? And so flow doesn't go in this direction where it's supposed to be. And that's what it's supposed to look like. So this is just a slide showing you how all these things are different from the way it ought to be with normal structure. And this is a slide that shows you the coarctation of the aorta. Here's the coarctation. Here it is again. It can happen here in the arch. It can happen further down. It can actually happen further down here as well. And so the pressure is going to be lower distal to the point of the coarctation, okay? So for these things, how do we pick up on this? Well, for mitral valve prolapse, they're going to have an early systolic murmur with a mid-systolic click, also heard best at the apex. If they're not symptomatic, and if you don't pick up on this, or it just doesn't, it's just not there, they will have anxiety, fatigue. They'll complain of what will make you think of angina. And your brain's first reaction is, oh wait, this can't be angina, but yeah, it can. They'll have palpitations. It'll be worse while they're standing, and the longer they stand, the worse it gets. They will also oftentimes have a pectus excavatum, okay? And they'll have a decreased anterior posterior chest diameter, and it's highly associated with scoliosis. So when you're screening people for scoliosis, you're listening to their heart, keep in mind you're looking kind of for this. Mitral regurg and mitral stenosis, if they're not actually symptomatic with something that's in the cardiac exam, again, they'll have fatigue, dyspnea, that kind of thing. They may have symptoms consistent with pulmonary edema, and stenosis can also show up with atrial fib. For mitral regurg, they'll typically have a holosystolic murmur that radiates to the axilla, best heard at the apex, and it'll get worse with Valsalva. So you always want to have these athletes do a Valsalva for you. And for coarctation of the aorta, if it presents when they're really little as infants, they're going to have tachypnea. They're not going to feed well. They're just going to be listless, and that's what the patients are going to bring them to you for. If they have it for a long time, they'll have symptoms of congestive heart failure. For adolescents, they'll oftentimes have elevated blood pressure, because of the pressure differentiation on either side of the coarctation. They'll have exercise intolerance. Sometimes they'll have headaches. There will be a difference, and this is a great way to pick up on it if you suspect it. There will be a difference in the upper and lower limbs blood pressure by at least 20 millimeters of mercury, okay? And so if you have that in the face of some of the history, that kind of thing, and again, they're going to have the asynchronous radial and femoral pulses. They'll sometimes have weakness in their legs, okay? One thing that I see from time to time with people who have a coarctation is that if you look at them just wearing shorts, their musculature and their development will be less below the waist than above the waist. I mean, you just look at them and you think, what is wrong with this picture? Either the person doing their conditioning doesn't know what they're doing, or something else is an issue. And I've actually been provoked when I see that and didn't catch it first time, when I see that, to go back and do a much better exam and have actually found a case or two just by noticing that. So that's been helpful to me, so I thought it might be helpful to you as well. Echo is good in all of these. And if you suspect any of these things, that'd be one of the first tests that I would consider. So one of the things that you can see in coarctation of the aorta, if you do a chest x-ray, is you can see what's called the 3 sign, where you have a bulge here and a bulge here, and it kind of looks like a 3 right there, and their heart will be enlarged as well. And you may also see kind of a little notched feature in the ribs. And these guys, remember, will have a systolic murmur, okay? They will have upper limb hypertension, elevated blood pressure, and lower in the lower limb, okay? It is associated with Turner syndrome. We had a mention of that earlier today. And again, get a chest x-ray. If you see this, then you've justified getting your echo, okay? So in terms of treatment, what do we do? Well, if it's mitral valve prolapse, we don't have to do anything really all that heroic. If the person if they don't have any history and they don't have any evidence of any kind of arrhythmia, and they've made it through a fairly detailed cardiac eval, they're probably going to be all right. If there's no family history as well of sudden cardiac death or early death. For mitral regurg and mitral stenosis, it depends on what kind of symptoms they have, what kind of compromise in their sport activity. If they don't have any issues with rhythm issues, they can probably do okay with sport. It is possible to repair both of these surgically if they are severe or refractory to more conservative care. If people are going to have valve replacement, you don't want any contact sports. If in the process of doing the valve replacement, there's a mechanical prosthesis, and if they're anticoagulated, this will contraindicate contact sports, not all sports, but contact sports. For coarctation, you just have to manage their blood pressure. You manage congestive heart failure if they have that. And if they're really severe, usually they will get surgery. And the good news is the prognosis for great recovery is really, really good. But these people, for the rest of their lives, will be at increased likelihood of developing coronary artery disease over people who don't have or haven't had a coarctation. If they have a family history of coronary artery disease, then that risk goes up even higher. So it's important to do the right kind of patient education, patient and family education. Other issues in terms of cardiac problems with sports medicine, some of our athletes use stuff, medications, whether they're prescription or not, to enhance their performance. The most common types of medications, anybody want to guess what the medication type that's most common that we see? Not just in the United States, but I see it with Olympic athletes as well. Stimulants, by far. And believe it or not, good old methylphenidate is still one of the most common ones that we see. It's very, very common. It is implicated in sudden cardiac death. The most common stimulant of all is caffeine, okay? Pseudoephedrine and ephedra, really, really common. These things can make you at higher risk for cardiac issues. Performance-enhancing drugs, substances, whatever, is extremely common at all levels of sport. They can absolutely impact cardiac function. There are lots of studies that have shown that if people use performance-enhancing substances regularly, particularly if it's steroids, it can actually increase your cholesterol and other lipids. It can impact your inflammatory markers in a negative way, and thereby increase your risk of coronary artery disease. One of the things that we see in very elite athletes is, and what we are trying to do with very elite athletes now, is to do some education about the fact that, they may take something with pseudoephedrine in it that's a non-prescription medication in some of these over-the-counter things. And one of the problems we have is that some of these in some countries are made where they don't have forbidden substances. The World Anti-Doping Authority publishes a list of forbidden substances every year. It's revised every year. But you can have, say, a drug for seasonal allergies that doesn't have a forbidden substance that's when it's manufactured in a particular country. But you can have that very same drug with the very same package label made by the very same pharmaceutical company in another country. And what these young athletes often do is they leave them at home and then they go to the pharmacy to replace them and get them in the other country. And they take it and they don't realize that there's one ingredient difference. And then they show up positive on a screening test. And then they're in trouble. So we're working really hard not only to make sure that we catch people who are intentionally trying to break the rules, but the way more common issue we have is where people are breaking the rules they don't even know. So we're working very hard on educating athletes and their entourages, so to speak. So performance-enhancing drugs are a very significant problem that affects cardiac health that we have to deal with. So from a practice standpoint, my suggestion would be that we use that standardized history question and physical exam. We focus on the cardiac-related symptoms, and we focus on symptoms with exercise, previous history of the athlete, previous history of the athlete's family. We assess their blood pressure. We check those radial and femoral pulses. We listen really carefully to their heart. If you're going to really be anal retentive and detailed about any portion of the pre-participation exam, it's this, okay? It's absolutely this. Now, in the United States, it is recommended that athletes who are determined to be at risk because of these things get a screening EKG. In Europe, every athlete, regardless of their history, gets a screening ECG, every single one from the age of about 10 on up, okay? And it's not optional. The American Heart Association recommends screening cardiograms in any athlete over 40, any athlete who begins a new exercise program. In Europe, everybody at every age gets a screening EEG, period, end of discussion. As far as screening high school athletes, that's a point of controversy in the literature right now. Here in the United States, the guidelines are that we do these historical questions, we do the exams that I mentioned, and if there's anything that's not right, then we might go for that screening. But otherwise, there is no recommendation for that, and third-party payers won't pay for it either. In Europe, everybody gets an ECG, and if there's any doubt at all, they get an echo as well. They just get an echo. So it's very common in all over Europe and Asia to have completely healthy, no history whatsoever issues with athletes. They've all had ECGs and they've all had echoes for screening. And here you see a scan of a heart that shows a lot of periventricular fat buildup and fibrotic tissue that actually interferes with, and it's on the long axis there, and it predisposes an athlete like this to sudden cardiac death. So again, this would be something you might want to do if somebody's symptomatic and they also have a contributory history. So it's important, if you're doing sports medicine care, to have a friendly neighborhood cardiologist whose expertise that you can use. You want somebody who is used to working with athletes, so that they can help you decide about return to play. You want to use a personalized rehab program if there are issues, not left just to protocols. You want to be sure you educate everybody, educate the athletes, their family, and their entourage, coaches, everybody, on what the risks of returning to play are. Even if you think they're okay to return to play, you still want to educate them about the risks of doing that, and about participating in exercise programs and that sort of thing, and how it's very important that periodically they have their left ventricular function reassessed. If you do exercise prescription, that's perfectly or fine, and it's fine for these guys to participate in exercise, particularly if their ejection fraction is over 50% and they don't have any reproducible ischemia. It's perfectly okay, but athletes should wait at least 3 months after any kind of a cardiac procedure before they start any kind of an exercise program. And monitoring them very carefully is very important. This is just a photo of at one of the Olympic centers of exercise tolerance testing that happens, and we evaluate left ventricular function. So there are some emerging things. One of the things is that we know that, or it's becoming more and more evident that alcohol-mediated septal ablation and myectomy can decrease thickness of the cardiac septum, which encourages left ventricular outflow and can improve cardiac muscle function in people who are known to have hypertrophic cardiomyopathy. And sometimes these are superior to medication if that hypertrophic cardiomyopathy is refractory just to medication. We know that minimally invasive and sutureless valve replacement may allow faster return to activity, but again, return to play is based upon their function of the valve, their cardiac testing, their ventricular function, and whether or not they're using anticoagulants. There's a new molecule, mavamectin. It's an allosteric cardiac myosin ATPase inhibitor that actually improves exercise capacity with obstructive hypertrophic cardiomyopathy. More about that is gonna, if I were given this talk a year from now, I'll have much more details, but that's pretty new. There is a concern over myocarditis for people who've had COVID infections, athletes who've had COVID infections. And so there are new protocols now emerging about cardiac magnetic resonance to detect myocarditis in those people who are at high risk, particularly at the elite level, who have had COVID. So I'm seeing with Olympic athletes and other elite athletes, we're seeing that procedure done more and more. Now, there are some gaps in what we know in the literature. The American Heart Association and the American College of Cardiology, they don't recommend universal cardiogram screening, as I mentioned, in healthy young athletes. In Europe, everybody gets one, okay? European studies show that if you take a history and physical and you add cardiogram, you have increased detection of cardiovascular disease and increased detection of disorders that are highly associated with sudden cardiac death. Okay, so there's a place where the literature is still not in complete agreement. We don't know what the correlation is between exercise and intensity and their risk of developing arrhythmia in people who have congenital heart disease. In general, we don't know. We know physical activity improves quality of life and it's good for your heart, all that kind of stuff, even if you have heart failure, but we don't have a lot of data about what the benefits of exercise are on survival with patients long-term with chronic heart disease. We don't know much about when it's the best time to start a rehab exercise program after someone experiences acute heart failure, whether it's an athlete or not. And we don't know a lot right now about the risk of atrial fib with really strenuous exercise after people have had cardiac ablation if they have atrial fib, regardless of what the cause might be. And we don't know a lot about the long-term effects of exercise on aortic root and the aortic valve and what the risk is of aortic dissection and rupture. That literature is still evolving as well. So, in summary, we've looked at epidemiology, the pathophys, we've looked at anatomy, we've looked at H&P, we've looked at diagnostic considerations, we've looked at treatment of some of the more commonly encountered cardiac issues, both congenital and acquired, rhythm issues, structural issues that we find in people who are engaging in regular, vigorous physical activity, particularly athletics. We've looked at gaps in what we know about cardiac surveillance and how to take care of these folks. And we've looked at things to consider in clinical practice in terms of what these athletes' needs are for care and their surveillance in the sports medicine setting. So I hope that's been helpful. And then the rest of the stuff is my references. So you can look at those and read more about it if you choose to. This is where I work, and all the DCOM graduates here are familiar with this facility. This is the medical school facilities, the athletic training room. This is our 5,000-seat arena, basketball arena. This is our new tennis complex, which if some of our earlier graduates, it didn't exist when you were there. And this is our brand new lacrosse facility. So So that's just where I do my thing. So thank you all very much, and I'll entertain any questions. I realize that I'm the only thing between you and the reception, so I'm sensitive to that.
Questions for Dr. Whiting?
Correct me if I'm wrong, but back when they had initially the COVID, I think Ohio State football players, I think they did MRIs on those players. They held up that Big Ten season. I think there was like 27% of those players, when they did the MRI, showed evidence of myocarditis, if I'm not mistaken.
Yeah, I don't remember the exact number, but there was a fairly high, way more than they expected. You're exactly correct.
And they held that up. So essentially, with COVID, there probably, if you did a lot of them, you'd found elements of myocarditis in that group. But it didn't seem like as they went on and played or went on through the thing, there was not increased incidence of sudden death in those groups of individuals, was there?
And the reason for that, you're correct. And the reason for that is those folks typically don't have any of the other associated issues that increase the likelihood of problems. And they're starting out with really good protoplasm to begin with. Yeah.
Anybody else? I just wanted to take care of a few housekeeping items. First of all, I'm Kevin Cope. I'm the president of the Alumni Association, and just wanted to thank you all for being here again. How many people are here for the first time? Oh, well. How many are repeat visitors? And then DCOM grads, non-DCOM grads, PAs, nurse practitioners. Special welcome to y'all. First of all, this CME conference, we recognize CME is a competitive environment, and we recognize your time is also very valuable. And so we want to thank you for being here with both your time and then also choosing to spend your limited CME dollars with us. Every year, this conference is put together based on the feedback that y'all give us. So this is not the Alumni Association's conference. This is not LMU's conference. This really is your conference. So at the end of the conference, the surveys that you fill out and get, we really use those. And every lecture that we choose to put in this conference is based on feedback from all of y'all that you give us. So please be honest with that feedback. A couple things for DCOM grads. We have 2 scholarships. One for Dr. Burt Routman that has recently become endowed but is still accepting donations. And then another one, Dr. Whiting, had a scholarship created in his name as well that we're working toward getting that endowed. So there's information about that around. Just encouraging donations for those 2 scholarships if you feel so inclined. In addition, this year, we also made Distinguished Alumni Awards and then a award for a Distinguished Community Physician. So if you think about it before you leave the conference, if you have any nominees for either one of those awards, please submit those. And the goal is going forward to award those at this conference in the years going forward. In addition, for DCOM grads, we do have some board vacancies, so if you're interested in being an Alumni Association board member, please come and find me, and we can give you the details on that. But most of all, we just want to thank you for being here. Amy Drittler, I don't know, y'all should have all met her when you were checking in. She puts in a ton of work. This is a year-long labor of love for her to get this thing rolling. We're very appreciative of all the work that she does, not only for this conference, but for our alumni throughout the year. But yes, we do have a social hour across the hall. I don't want to hold us up any longer. If you have any questions, concerns, comments about anything that's gone on at the conference so far, please feel free to come and find me. I'm happy to speak with you. But most of all, thank you for being here. Welcome, DCOM grads, not DCOM grads. We're happy to have you. We love having you here. This is a highlight of my year personally, is being here and having everybody here. So thank you.